9:30, so I'll just wait for the thumbs up to make sure we're online to the millions waiting. Absolutely, we're ready to go. So, thank you very much for everyone for your attendance this morning. Obviously, we've got a packed agenda in front of us. Before we do the formal items, just obviously want to put on record my thanks to Sue Hannington for her previous position as chairman of the committee and the work that she's done, and to wish her all the best in her new role. Obviously, I'm delighted to be appointed by the full council last week to the role. I've been involved in Scrutiny for nearly 10 years, and I know how important it is and the difference we can all make as part of the Scrutiny process. So really looking forward to working with you all on the committee. So, agenda item 1 is minutes of the last meeting held on 14th November 2023. I will take it as everyone's okay with that shoe record. Any problems with that? All okay if I sign it as accurate record? Great, okay, shall do that. First, thank you. Item 2, apologies for absence. No?
We've had apologies from Councillor McGrath for medical illness, with Councillor Fall substituting, and we've also had apologies from Sarah Collis of Health Watch.
Great, thank you. And thank you, Councillor Fall, for substituting today. Item number 3, a declaration of interest by members and officers present.
My husband's community staff nurse.
Thank you.
Personal, it mentions the Donna Ockenden review, and obviously I'm involved working with Donna Ockenden with regards to it.
Okay, thank you very much. Any other interest to raise? No? Okay, so we'll note that down the record. Thank you very much. So, on to substantive items. Item number 4, which is the Newark Urgent Treatment Centre opening times. So, obviously, from reading back through the minutes and watching all yourselves online in the previous meeting, I know how much this has been scrutinised before and the efforts of this committee in terms of the views put forward. And from my chats with ICB and NHS colleagues, I know that very much has been taken on board and appreciated. So, glad today that we are joined by representatives. So, we've got Lou Studd here, but we've got Victoria Greg O'Reilly, who's joining us online. So, welcome, Victoria. Alex Ball, David Ainsworth, and Dr. Ben Owen. So thank you very much for your time today joining us. So we're going to be going through the reports. Obviously, I'm very conscious of the amount that's been scrutinised already, and thank you very much for that. So the report in front of you today is very comprehensive. So we're going to look forward to the officers here present to take us through the item in front of us. So who's kicking off? Alex, you kick off. Thank you very much. Over to Alex.
Thank you, Councillor Wheeler. Good morning, everybody. I'm just checking, Victoria, can you hear us? You've texted me to say you can't hear us, and I think that may still be the case. So I don't know. We'll proceed, but if there's any way some clever fiddling could go with the technology in the background, Noel, that would be very helpful.
Yeah, we'll look into that. Sorted.
Thank you. So good morning, everybody. I'm Alex Ball. I'm Director of Communications and Engagement for the Integrated Care Board here in Nottingham and Nottinghamshire. We're going to take a few minutes just to kind of orient you to the materials that we've shared as part of your papers. That will hopefully be a double act between me and Victoria, or it may be me doing a solo performance, which will be very exciting for everyone. So if you just click onto the next slide for me, please, Noel. I just want to remind colleagues, as we've discussed, I think, several times in this forum, the local NHS's commitment to Newark Hospital is not in doubt. We are fully committed as an NHS to ensuring the hospital is an important and vital part of the health and care landscape in Newark. And in fact, the hospital has already benefited in sort of recent months from a considerable expansion in services, £5.6 million worth of investment in a new operating theatre, and we expect there to be many more and further developments to bring a wider range of services to the people of Newark. And in addition to that, as an NHS, we are committed to maintaining an urgent treatment centre at Newark Hospital in line with the national specifications for urgent treatment centres. So the conversation we're having and that we have had with you over recent months and will continue to have is about the opening hours for the urgent treatment centre, not about the wider hospital or about the existence or otherwise of an urgent treatment centre, solely about the opening hours. And the purpose of today, as you can see on the screen, is to update you on the outcome of the listening exercise that we conducted over the autumn, to talk to you also about the feedback from the Clinical Senate, and I'll explain a little bit more about what that body is when we come to it. And then I'm hoping Victoria will then be able to come in and talk to us about the options appraisal process and what the next steps are for our work on this topic. So, next slide, please. The listening exercise that we conducted over the autumn, this had two core purposes, two things we wanted to achieve with this activity. This was to understand whether the current opening hours for Newark Urgent Treatment Centre were seen as suitable by local residents, or indeed if there could be other ways to spread those existing opening hours across the day, and also to check that the other ways that exist to access urgent care overnight are working as well as we believe they are, so that we're serving the local population's needs as best that we can. So we were out and about live with this listening exercise between 4th of September and 17th of October, and you can see set out here and in your papers the variety of different ways that we listened to citizens, to wider stakeholders, to other interested parties. We spoke with colleagues like yourselves and more widely, for instance, both publicly and privately. We mapped and met with community groups all across the Newark and wider community. We spoke to them and said, look, can we come and talk to you? And through that, we reached carers, young families, people with long-term conditions, residents of supported living facilities, a whole range of different ways to hear from people on their own terms in their own contexts. We held 6 public events, face-to-face predominantly, with a couple of online events as well. We ran a survey that was available online, on paper and over the telephone, and we published a considerable amount of material on social media and in the traditional media, which generated comments and feedback as well. In total, we heard from 1,932 people, set against the population of Newark, 30,000 people. That's quite a considerable sample of that local area population. So we're really grateful for the population of Newark coming forward and giving us their thoughts, unmoderated, unrestricted, and we've gathered all that information together. So what does that tell us? What have we learned from that, please, Noel? Really clearly, in terms of the headline findings, all the detail is in your papers. More than 70% of respondents to our listening exercise do not agree that the current opening hours of the Urgent Treatment Centre are suitable. They disagreed that they were an appropriate set of hours for them to access the service. And in fact, this was slightly stronger when we look at people who've used the service in the last 12 months. That grew to 74% of people. So we are clearly hearing there from the population that there is a level of disquiet around those current opening hours. And in fact, the majority of people said that they would prefer for the urgent treatment centre to be open 24 hours or for there to be an accident and emergency department available at Newark Hospital. We asked people to kind of sort of try and imagine for those 13 hours that the centre is currently open, 9 a.m. to 10 p.m, we asked them to think about if that were the opening hours or the available volume of hours, what would it look like if that was open earlier in the day, say, or later in the day? Was there any kind of particular preference, thinking about people's different lives, people who may have caring responsibilities or work or childcare responsibilities? Might there be a different way to arrange those hours across the whole period of the day? There was no consensus on that. We weren't able to kind of sort of draw out or elicit any particular preference. Of the options of a bit earlier in the day, a bit later in the day, or about the same as they are currently, there was a slight preference for them remaining as they are currently, but it was very marginal. And for people who said perhaps they would have preferred an earlier or a later kind of session within the day, that was very much about fitting around working hours or the service being available when other services might be closed. So that's kind of some headlines from that part of the listening exercise. If we go on to the next slide, please, because we also asked people their sort of more general views on how they access out of hours urgent care. And we sense checked where else people accessed urgent care outside of sort of normal kind of daytime hours. And you can see here the 5 ways in which people access urgent care. Of course, the urgent treatment centre, but also 111 over the phone, A&E, particularly at Kings Mill, and out of hours GP appointment and pharmacy. So it is important to note, and it's something that we that we stressed both in earlier conversations with yourselves and also with the public, the range of ways in which citizens and residents can access urgent care out of hours is wider than just an urgent treatment centre. There is a wide range and indeed growing range of different ways that people can access urgent care. So that is an important point to note. And gratifyingly, this was our hypothesis, but I think it has been borne out. A large proportion of responses to the listening exercise, when we asked them, how did you feel about that access to out of hours urgent care, they were really, really positive. People described getting compassionate care, their needs were met. They were particularly really positive about the personal interactions with the staff in all those settings that they underwent. There was some sort of dissent or kind of disquiet around how quick and efficient those services were. Sometimes people did get seen and treated really quickly. Other times they felt that the wait was too long, and that's something that we will need to think about. But again, the feedback, particularly around the staff, people were saying things like the staff are lovely, the staff were great, the whole team was excellent. So an important reminder, if we needed one, it is the people, not necessarily the physical buildings, that make the service that people really value. So that's the headlines in just 2 slides of our listening exercise. If we move on now to sort of the second strand of how we've been considering different parts of evidence and different information as we start to move forward to consider what decisions we might want to make in the future. We have also worked with the clinical senate. So just colleagues may be fully appraised of what the clinical senate is, but I'll just quickly kind of explain what that is. So this is an NHS arrangement. It's not an organisation as such. It's a kind of collection of people, but it's an NHS sort of activity. It's independent of the Integrated Care Board. It's independent of Sherwood Forest Hospitals. It brings together senior clinical leaders from across both East and West Midlands on request to give advice, guidance on the best clinical practice when integrated care boards are thinking about making changes. So it's a really, really useful resource that we can draw on to say, we're thinking about this idea, here's some of the things we've already considered, what do you think? And our Senate in the Midlands is really, really strong. They put together an excellent panel for us, 20 or so representatives, nurses, doctors, hospital doctors, GPs, patient leaders, many others. And we underwent quite a sort of rigorous process with them. We submitted lots of information and evidence, data about the workforce, about attendance, CQC reports, huge kind of pack of information. And then the panel rightly came up to Newark Hospital, visited in mid-October, spent the day there. We had a discussion as leaders from the ICB in Sherwood Forest. The panel toured the department, spoke to staff, spoke to patients, and then have fed back to us. And again, you have the complete report in your pack. We're publishing that today for everyone to look at. The 2 headlines I think I'd kind of really call out. Firstly is the Senate was really impressed with the quality of the care being delivered at the Urgent Treatment Centre and really commended the staff there for their work and for the kind of care that they were delivering. And then secondly, after extensive discussion, the Senate unanimously said that the Urgent Treatment Centre should remain closed overnight. And that was based on the evidence that they saw, but in particular the data on service usage, both pre and post-COVID, but in particular in that pre-COVID period, the number of people using the service overnight. The Senate felt that the number of people using that service overnight and the seriousness of the issues people were presenting with just didn't warrant the staff that would need to be available. And in their view, if the Urgent Treatment Centre was open, say, for 24 hours, the staff would have to be moved or rotated from the daytime rota, which would probably have an adverse impact on staff morale, recruitment, and the quality of the patient care that would be delivered. So that's 2 of the kind of strands of information that I think we've sort of described quite consistently that we would want to listen to our population, and we have. We would also want to listen to our clinical leaders, which we have, and we will also consider other factors such as the best operational practice, other elements of kind of clinical safety and the operating model. And that all feeds into what we call an options appraisals process, which I'm hoping that Victoria has been able to hear us and knows I'm now handing over to her to talk about the options appraisal process. Victoria.
Thanks, Alex. Can everybody hear me okay?
Yeah.
Yeah, brilliant. Okay, so first of all, apologies from me that I'm not able to be in the room with you. It isn't by choice. Had a bit of an accident over the weekend, so I do have mobility issues at the moment. So apologies that I'm not there in person, but hopefully everybody can hear me okay joining you virtually. So moving on then, as Alex was alluding to earlier, there have been two pieces of information to put into what's known as an options appraisal process. The diagram that you can see here, this funnel diagram, illustrates how that process works, where we bring together colleagues to consider a whole wide range of possibilities of future operating opening hours of the Urgent Treatment Centre based on the feedback received to date through all the various listening opportunities and feedback we've got from stakeholders. So the long list is then generated into what's known as a shortlist, and a potential preferred way forward will come out at the end of that funnel process. We arrive at the long list by applying what's known as hurdle criteria, and this includes things like ensuring that any option met National Urgent Treatment Centre standards and retained a minimum opening hours of 12.5, which is a commitment that we gave very early in this entire process. So those are criteria that we are saying should always be met, whatever comes out of the options appraisal consideration. We ran the options appraisal over 2 half-day workshops, and those were undertaken at the end of September, so relatively very recently. The group that we brought together, and as demonstrated in the slide there, to help us consider the options was a diverse collection of experts. So we had operational leaders from the hospital, local GPs, colleagues from the Newark voluntary sector, a Newark hospital governor, representatives from partner organisations, etc. And following these 2 sessions, we did actually produce a shortlist that we now intend to share with decision makers within the ICB. And I'm sure that you can appreciate that this process is a very robust one, and therefore the outcome of that process is necessarily confidential for now. But we wanted to be really clear as part of this conversation with you today where we were in terms of having undertaken that process, and be giving you the reassurance that it is both robust and follows national guidance. So just to give you the clarity again, although there are organisations on that table that you've just seen, the options appraisal panel included members representing clinical, public health, primary care, commissioning, operational, communications and engagement expertise. So a whole breadth of multidisciplinary understanding and representation in that conversation to arrive at the options that we did. So for the next steps, you can have the next slide, please. We want you to be, again, rest assured that all of this information that we've gone through, from the listening exercise, from the clinical senate, from the options appraisal, and also from the conversation that we're going to be having with you today, will go through to the ICB's decision-making process over the coming weeks. This will also include any feedback that we have from ongoing dialogue with NHS England regarding next steps, to ensure that we also meet the expectations of NHS England's assurance process. When we put all this information together, the ICB leadership will consider all the feedback from these various sources, as I said earlier, including the conversation that we'll have with you today. And we expect that conversation to be had within the ICB over the next coming months. If we move to slide 10, please, for recommendations. So, as I've mentioned previously, an important part of this process is being here with you today to make sure that you're aware of the processes that we've undertaken so far to consider the future operating and opening times of the Urgent Treatment Centre. As I've mentioned, it is the combination of the listening exercise, the clinical senate review, its recommendations, and describe and outline the options appraisal process to you. And as part of the conversation that we would really like to have with you today, we'd like to consider how we keep this committee updated as we continue to move through this next stage of the process, and our ongoing engagement with the ICB decision makers. And at this point, we'll close the presentation slides, and very happy to take any questions that members may have.
Okay, well, thank you very much to Alex and Victoria for that presentation. And Victoria, I'm sure we all wish you a speedy recovery. So thank you for joining us remotely today. So before we get into these substantive items, also we've got recommendations in front of us in our report, which align with the recommendations that come forward from the NUH fund and from the NHS and ICB, which is note the finding of the listening exercise, that we note the feedback from the clinical senate, that we note the outcomes of the options appraisal, and as a committee we consider next steps and actions. So before I open up to the floor, just a couple of points I want to raise first of all before I come back later on. So on page 27 of the report, one of my main concerns is that before it was closed overnight during 2020 for the COVID pandemic, overnight, circa 1 in 3 days, it was closed overnight because it was impossible to staff the rota with the required number of staff to provide a safe service. So, if the service was to be brought back in overnight, say from the new year, do you think that situation has changed for the better, for the worse? Would it, because that's my primary concern, if you reopen it, then obviously the service is not there. So just Ben, thank you.
Just coming on that, thank you. It's a sensible concern, and it's a concern I would share. We still, the main reason during that period it was closed down overnight was we'd exhausted everything. We'd gone to agency or locum bank staff. We'd gone to could we move anyone from the emergency department at Kingsmill, and only at that point did we shut it. That hasn't changed, and the demand at the Kingsmill site is significantly greater than it was at that time. So I can see, yes, that is, if it was to reopen overnight, the same scenario would occur. That if we couldn't staff it, it would have to shut because we can't. There is a shortage of staff out there, and that's one of the main drivers of that.
Okay, thank you. Sorry, before I bring Councillor Martin in, just the point as well to make sure I'm reading the bar chart correctly. What was the average amount of people who were coming in on an evening to the Urgent Treatment Centre when it was open 24/7? Ben.
Thank you. So between 10 p.m. and 8 a.m. there was about 10 patients a day coming in overnight. If you take that after midnight, it was from 1 a.m. it was 2 patients. So you had either 10% of the footfall, about 100 patients a day. It's about 10% of the footfall taking up nearly sort of 40% of the staff's time. Or if you take it overnight, you have 2% of the footfall taking up a third of the staff's time because those staff have to staff the different things. So the number is incredibly low. What's happened since in that period of time has been closed overnight is that the number of people attending in the day and early evening has gone up, as you'd expect with healthcare demand, and as we see with every other service that has gone from a 24-hour to a 12 or 13-hour service, is those people, because their needs, when we audited it, we did multiple audits of this, their needs are urgent needs, not emergency needs, and we've also got a lot of scrutiny of the ambulance transfers from the Newark area to the Kingsmill site. And the thing that has not gone up for the patients that arrive at Kingsmill Hospital by ambulance, their chance of being admitted into the sickness hasn't changed in that period. So we're not seeing more sick people coming across. We're also not seeing less sick people coming across. It's the ambulance activity is as it was, if that helps.
Thank you for all that background context. So first on my list was Councillor Martin.
Yeah, thank you, Chair. It's a big subject, as the papers reflect. First of all, I'd like to congratulate you on your new position, although I do find it a little cynical that Councillor Saddington was removed at this juncture, because obviously as a Newark councillor, she's got a vast wealth of knowledge and passion about this subject, and there's no detriment to your character at all. I'm just saying, I thought it was a bit cynical that she was moved at this juncture. Of course, 4 years ago today, in the last election manifesto, the government, Boris and his clan, promised to build 40 hospitals, and in that time we've only had 2 built across the country. And of course, satellite hospitals like Newark would vastly be vastly much more beneficial to the public with the investment, as Alex has already alluded to. They've alluded to 5.6 million and more to come, but it's not enough because the population mass is set to grow. I mean, probably Councillor Girling over there could tell me, but I'm sure it's somewhere in the region of 25,000 Is it growing? How much is it growing, Keith?
David, sorry, I understand the point there. Obviously, Keith's not parliamentary to observe, so I understand the point you're making.
But the population expansion of Newark is, and also when you consider the demographics, especially, I mean, I know myself and Councillor Darby, when we were wandering around Coddington, the age of people is much more important to them to get treated quicker. And of course, you would say, why am I so concerned as an Ashfield councillor? Because it affects Sherwood Forest Hospital's trust at Kings Mill, which has an excellent A&E with a great turnaround time. And I've seen all the statistics, and I was very surprised that EMAS get people from Newark and Sherwood over to Kings Mill in the same time frame as they get them from the peripheral areas of Ashfield and Mansfield to Kings Mill. That is a tribute to EMAS in itself. Obviously, as plain as the nose on your face, the public are going to say they want more. As plain as you know. So I don't know how much this has cost, but obviously it's a tick box exercise that has to be gone through. I don't think the NHS, no disrespect to any of you, but I don't think the NHS were ever planning to open the urgent treatment care centre at Newark for any longer than it was. And I've got to just pull you up on one thing, Ben, is that the statistics are stifled because A&E has been shut since 2010. So since 2010, the whole psyche of the people in Newark is Grantham, Kings Mill. So people haven't been going there. So that it doesn't reflect the whole picture because they're going to Lincoln, they're going to Grantham, and they're coming to Kings Mill. So this does not reflect the whole picture. And if you tell me it does, then I'll admire and respect your because you've got the statistics on it. But from my point of view, I know that people go to Lincoln and they go to Grantham outside that. And the real crux of the problem is money. And of course, staffing is another issue. We know that. We've seen that in Bassett Law with paediatrics. It's always going to be needed more. But at the end of the day, the plethora of services that are delivered through an A&E cost a lot of money. And they need a lot of skills. That's why Kings Mill's got them. And also the current demographic population of Newark, as was alluded to at the last meeting, I think it was in September, doesn't warrant Newark having an A&E. But it certainly warrants it having an urgent treatment care centre. And it's clear that people want it to be opened. They're not being clear on the hours because you've got equal parity where some want it open earlier, some want it open later. So it's always going to be a difficult thing for you to sort out. But in the end, I hope you do listen to the people, because listening to them and doing something is a completely different thing. Thank you, Chair.
Okay, thank you as well. I think there's points they raised about the Children's Hospital. So are you right to come back in, Ben, on that?
Thank you. Yeah, so the understandable concerns. I take a couple of things. I think from a Kings Mill emergency department and hospital site process, so I'm the urgent care lead for both there and Newark. We do support this in that there's a primary care service 24 hours a day attached to the emergency department at Kings Mill. So patients that have an urgent need, if they do end up coming across out of hours, are met by the primary care service there. The second thing is around so Grantham. We've done a lot of postcode analysis on this, and Grantham see 28 people a month from the newer postcode areas. So it's one person on average, one person a day. And in the Kings Mill site, we've not seen obviously that's our own patient group. We've not seen that, and the ambulance conveyance tells us the same thing. So it hasn't. We have not seen. And the response and this time to be seen at Newark Urgent Treatment Centre, despite the raising, so we've gone from about 70 to about 100 a day patients, it's still performing at 98% are seen within the 4-hour window. So the service they get when they come are pretty quick. And if anything, we're a net importer of people from surrounding postcodes at Newark Urgent Treatment Centre rather than exporter of patients. And I understand the concerns completely why you asked that question, and there will be some that do that inevitably. But the statistics say it's not an issue that we can see, to reassure you.
Thank you, David. Did you want to comment?
Yeah, thank you. Morning, everybody. Thanks for listening to us. And Councillor Martin, there's quite a lot in what you said. I might refer to Alex if he wants to make comment on the issues you raised around the listening exercise. What first of all, what I'd like to say is thank you for your kind comments about Kingsmill A&E and our turnaround times, which are an average of 15 minutes. And that's something we've worked really hard at and have maintained over the last 5 years, and really proud of that. And, you know, we're in a public setting, so, you know, I pay tribute to Ben, Andy's, you know, all the team that sit behind Ben that achieve that on a daily basis. I think we're here to talk about the opening hours of the UTC. I think Alex was right to remind us of that, but you brought up the investment in Newark, so I will just take the opportunity to say, you know, at Sherwood Forest, we're immensely proud of the achievements over the last 12 months at Newark Hospital. They've been rapid, quite frankly, in their implementation. So a brand new operating theatre delivering additional, so we're not moving work, these are new additional slots. So there'll be 2,500 at least operations a year, every year from Newark Hospital site. That's new slots. That's great news for people who are on the backlog waiting list that we know is all important. We're working really hard to try and clear. It also means, as rightly said in the presentation, we can offer a much broader range of services from Newark now, which is great for the local population. So we've reintroduced hip and knee operations, shoulder operations. We've introduced gynecology. We've now got a breast one-stop clinic. The list is kind of endless. I won't take up committee members' time with that any further, but you get the sense, I hope. And with the fantastic partnership with Newark and Sherwood District Council, in February we'll have a brand new car park on the side of the hospital, which will bring in additional 80 car parking spaces, which, you know, frankly will be great news for the local people as well. Really grateful to the local population of Newark for engaging in this, and we're really proud of Newark Hospital, and we see it going from strength to strength. Thank you.
Thank you very much, Alex.
Yeah, just to respond to a couple of points that Councillor Martin made, just to be really, really clear, this is not a financially driven kind of process that we're in. This is about making sure that we have a safe and sustainable service within the urgent treatment centre. So I do think it's really important that we're clear on that. And similarly, we committed to this committee and more widely that we would listen to the population of Newark. And I hope we can demonstrate here that we have done quite an extensive piece of listening over the autumn. But what we also said really clearly is that we would set that information alongside the feedback from our clinical kind of experts, which we've done through the Clinical Senate, and also alongside the operational kind of constraints and information that Ben and others have touched on. So it's always a balance, isn't it, of trying to kind of thread together all of those different competing demands. As you said yourself, Councillor Martin, if you ask people, do you want more services, they're going to say yes, aren't they? But I want us to be really clear, we have not yet made a decision about what the future opening hours of the Urgent Treatment Centre will be. Why we are here today is because this committee has been extremely interested in this process, so we wanted to make sure we had a interim update and put on the public record what we've heard from two of those kind of strands, as I've mentioned, what we heard from the public, what we've heard from our clinical leaders, and also update you on what some of our next steps are. But I need to stress again, we haven't made a decision on this matter.
Okay, thank you. So, David, I know you put your hand up back again. Right, to go to another councillor and come back to you after that. Okay, thank you very much. So, Councillor Fold.
Yeah, thank you, Chair. And just to give our thanks to Sue Saddington, I think she was a real passionate, hard-working chair and impartial. She did a fantastic job. So thank you to her, and all the very best to you, Councillor. I hope it goes well for you. Okay. I do really question, to be honest with you, whether this is not really a funding and a resources issue, but I'll perhaps come back to that in a minute. But in terms of the consultation, I mean, it's more than 70% of survey respondents disagree the current opening hours of the service is suitable, and a similar view was heard in public meetings. And I get that you've got these kind of competing kind of views about what the situation is, but it does still feel, in terms of the consultation, that the public voice is that their voice is falling on deaf ears, really. And I think the point was well made by Councillor Martin. There's more building going on in Newark. The demand could very well increase kind of quite quickly. And local people are saying we need this service and we need it for longer. I think it's very, very clear, and I think that really is something that needs to be higher up in terms of the priority when you're listening. Under the proposals, the suggestion for A&E access for Newark residents is that they attend Kingsmill, and sounds like some great stuff going on in Kingsmill as there is in Newark Hospital. But we've done a bit of research, and around about 8 o'clock in the morning, a car journey from parts of Newark to Kings Mills will be in excess of an hour. And people are travelling from Mansfield, Lincoln, Sheffield, and these people are kind of in urgent need of help, aren't they? And I think, to just rely entirely on the data of the number of people coming in isn't really enough. And I tribute to the staff and tribute to you. There's clearly some great work going on. I don't want this to anywhere to be seen as a criticism of what's going on there. The quality of care is really great, but I'm really glad this decision hasn't yet been made. So a plea from me: please listen to local people who really, really clearly, in big majority, in big numbers, want this to be open for longer. Because it's very clear from the listening exercise that they want Newark UTC to be open 24 hours and possibly even to provide accident and emergency service. So is this something that is currently still being proposed? And if not, why not? One thing to come back as well to the ICB, and this is a more general point, and it's something that I've been very concerned about ever since its inception. It's just an inception. When I sit on observing ICB meetings, and I look at the kind of things you're discussing and the massive scope of the ICB, integrated ICS, it becomes very evident to me that they appear very far removed from people's kind of experience when it comes to accessing healthcare. And I know it's difficult, and I know that budgets are very tight, and I still challenge you on that one. I still think this is down to money and the lack of staffing, the difficulty of recruiting staff in the current climate. But I really do think that sometimes the data, the clinical kind of view predominates and actually doesn't hear what local residents want. And I think that's a real risk with the ICB when it's such a big, I would say, cumbersome kind of type organisation, and one that I think needs to listen to people more. Thank you.
Thank you. Alex, you want to just that?
Yeah, very happy to take that. Thank you, Councillor Fold. Again, I'll just stress, and you said it, but I'll say it again, we have not yet made a decision on this. To your plea for this not to fall on deaf ears, I completely agree. We are here to not only share with you what we've heard thus far, but also to further hear from you on behalf of your constituents and your residents what their views and opinions are. That does have to be set alongside, though, other considerations, the clinical kind of view, operational matters as well. So it is a really difficult balance and one that we wrestle with within the NHS and within the Integrated Care Board on a daily basis. But I do want to, I think, sort of ask for your agreement that we have listened extensively so far. The proof of the pudding will be in what those next steps look like and how we kind of take that decision forward. So I'd ask you to kind of sort of withhold your judgment perhaps about what we do about that and where we go next with that. But I want to stress that our commitment to listen to the population of Newark has not wavered since when we started off on this process, but we have also consistently said that has to be set alongside other factors as well, so that we can come to a rounded decision.
Thank you. Ben, do you want to come in?
Thank you. Yeah. So thanks for your sort of points and questions. I think just on the clinical context, because it's come up a couple of times and a couple of things. In terms of an emergency department, accident emergency department, it will require an entire new hospital. There's no intensive care. There's no paediatric service. There's no significant overnight operating theatres. There's thousands of staff will be required to back up an emergency department. So it comes up regularly to reassure the population, the people here. It was classed as an emergency department 13 years ago, and the cover behind Newark, behind it, was no more than it is now. So by the modern definition of an emergency department, it never was one. and that's why it was at the time correctly rebadged as an urgent treatment centre. But it's so far away from that possibility, because the population, even if it grows by 25,000, is nowhere near the size it would need to have an emergency. But I understand when people ask that question, totally. The second thing is around the population growth, which has come up twice. So if this is an urgent treatment centre should treat people who have urgent needs, so things you'd see your GP with, or minor injury, minor illness, that's the population that should attend or use in your treatment centre. If it's urgent, if you called your GP, they would say, I'll see you at 4 o'clock, 8 o'clock in the morning, I'll see you at 4 o'clock, you'd probably say, okay, that's okay. So if you have an urgent need, it's 8 a.m., it currently opens at 9, which for them may be inconvenient. I can understand that completely, same way. But actually, it's an urgent need, it's not an emergency. So to make the best service we can for urgent needs, it's concentrating on the staff at the time that people actually do attend. The second thing is, if the population grows and the emergency need changes, if we're clearly saying to people, if you have an emergency, you should not go to the urgent treatment centre, whether it's open or it's closed. Not because the staff aren't great, they are great, it's been recognised, and thank you for all the kind comments, because they haven't got the backup if you're a true emergency to deal with you. They will actually delay care rather than getting an ambulance and going to an emergency department. So the population growth, actually, by keeping the staff in the day and the evening time, we've met a 30% rise in demand by doing that, and actually increased the staffing there. It's recruiting staff to the overnight that we cannot do, because those staff, it's not a popular way of working to work nights, and we have improved the care in the daytime by moving the staff that would have covered nights from a nursing point of view, which is less of an issue, into the daytime. So the service is better from what we've done. If it was to change back, we would take those staff out of the day and put them back into nights, and you'd have a worse service with longer waits in the daytime for a tiny portion of people that were using it. So just to reassure you, people around the population growth concern and the emergency department question, that's just, we are absolutely here and genuinely believe that the service we provide now is a better service for people in Newark than it is the overnight service in terms of urgent care. I hope that helps.
Okay, David, can I come in?
Yeah, thank you. Thanks very much for your comments. Echo what Ben and others have said. Just on the two or 3 points, if I may. On the listening, Alex, Victoria, Ben and I were present at all of the listening exercises, so I can give you absolute assurance that we were listening, and in fact they had a time slot, but we all stayed afterwards as well and allowed people to come and speak to us individually if they so wished, and a number of people did, and many came to give positive feedback, and we found 1 or 2 people that had suggestions for improvement going forward. So I can say with confidence that we heard what people were saying because we were there and present ourselves. I think Sherwood Forest as an organisation has a very strong track record of the way that we deal with our workforce and our people. We have fewer vacancies than many of our partners in the system around us, and last year's national staff survey that all organisations across the NHS complete placed us second nationally for the morale of staff, something to be recognised, celebrated, and it doesn't happen by default, it happens by a whole load of hard work. So if we are having difficulty recruiting people, you can bet your bottom dollar it's because of genuine reasons, often national and outside of all of our control. One of the things I want to be able to give people, however, whatever decision we reach collectively when this matter reaches that point, I want to be able to give people certainty. And before COVID, we couldn't give that. So it was highlighted, Chair, by yourself as, often people would pitch up, 3 o'clock in the morning with somebody who's sick or they're worried about, to find the doors closed and the lights off with a sign on saying due to unforeseen circumstances. We have to bear that in mind when we reach the decision, whatever decision we reach, because there is a possibility that could happen in the future if we go for a 24-hour service, given the workforce issues that we've described eloquently so far. So certainty matters to me. I don't want people to feel uncertain. And just linked to that, what was really clear in the listening exercises to me was that we still have more work to do in helping people understand the urgent care system and what else is on offer outside of the urgent treatment centre. So people don't need to travel an hour at 8 o'clock in the morning. They can ring 111, or they can go online to 111. There are seven prescribing pharmacies in Newark who are doing trials on prescribing medication, simple antibiotics and the like. So there are other services, and what local people said at all of those events is they don't truly understand the urgent care system and what else is on offer. And, you know, quite frankly, I think in the round of whatever we end up with as a decision, we all have a collective duty to help people understand what is available and how they can access it. Thank you.
Okay, thank you very much for that. Councillor Walsh.
So, where to start? A lot of people already said what I was going to say. So, I want to talk a bit about health inequalities, if I may. But perhaps start by saying how, and I think you've just alluded to it actually in a lot more detail, how urgent treatment centres are actually becoming more and more critical to how we deliver health services at the moment, and will be none more so critical than this winter, I think. It is slightly different in Shield Forest. I don't think they felt the pressures as much as what they have certainly in QMC at the moment in their A&E, but the urgent treatment centres are absolutely critical. I'm not as confident as you with regards to 111 and how that works and access to it at all. And I think if you did a consultation on that, you would get some very, very interesting results with regards to it. Urgent treatment and urgent care is difficult for a lot of people to access. There is no doubt about that. And if it doesn't work, there's a problem. So if I just talk about page 4, where you're talking about future 24-hour provision, and it's detailed in the blue boxes, it says priorities for urgent treatment centres are detailed in blue boxes, page 4 of the report, page 16 of the committee papers. These include open 7 days a week, 12 hours a day as minimum, typically increasing to 24 hours a day when co-located. How long do you expect it to take for the co-location conditions to be in place for the UTC to be open and offer those health services over 24 hours on that basis? Or is it going to be how you've described it, that when it's closed there are a number of other options that we need to put in place, such as 24-hour pharmacies, etc., and how that works? My other question is, what is the pressure on your UTC at the moment? So I've had residents contact me, and this is different. I don't represent a ward in the Newark area, so I get to know about the other end. But there was 7 or 8 hour wait in UTC at the weekend in Nottingham. What is the wait like at the moment? Are you feeling the pressures already? Because my next question is, when it gets to winter and more flu, more pressure on Shield Forest Hospital Trust, UTC is going to feel the pressure more. And is it that those 24 hours could actually play a huge part on the health of those people living in those area? And then the other thing I want to address is, we've talked about the fact that about A&E access for Newark, how it's a minimum of an hour away. And I wanted to talk a bit about health inequalities with regards to that, because if you've got somebody, if you're travelling that way, it's more cost, you're off work for longer. And I get completely what you're saying, and I think you should be commended with regards to the staff. As a trade union representative, I've never been called to help anyone at Shield Forest. I can't say that for all hospitals. But it's a question of that hour and that difference from A&E. What are we doing about it? If we're saying it's not going to be there and that's not possible, is it being addressed at all? Because it does feel like the people of Newark get a bit of a raw deal with regards to it, and there is that greater way to travel. So I was just wondering what we're going to do about it but what is going to be done, or is that just it? You travel an hour to get to your A&E and that's it. So a couple of things really. Pressures on UTC, the fact that it's acknowledged that this is absolutely critical, and just to really, I hope that makes sense.
So a few points there. So tell you what, David, to take the pressure off, you can go first and address those bits. Thank you.
Great, thanks. And if it's okay, I'll start, and Ben will do the bits on the waiting times and the like, if that's okay. I just want to be really clear. We are feeling pressure at Sherwood Forest. I don't want anybody to leave with the impression that we aren't. We've got over 100 extra beds open today. We're on our utmost highest escalation today. Ben was on a call about the beds at King's Mill, and we've opened ward areas at Newark Hospital as well to help with the increase in demand. So don't leave feeling that just because we've got really good ambulance turnaround times of 15-minute average per month and really good performance against targets, that doesn't mean that there's a whole load of hard work at Sherwood Forest going on. And those beds have been open for over a year. 111 extra beds open above what we normally have open, and we're now talking today of opening more more beds and more cubicles. So the demand is there on the NHS. It's a good time to say to people, do everything you can to look after yourself, get yourself vaccinated. You're right to talk about flu and COVID. They are rife in the community right now. If you've never been vaccinated, it's the best form of protection for yourself and the loved ones around you. And we'll always welcome you with open arms for a vaccination if you're not vaccinated. And we call upon the public to do what they can to look after particularly elderly, vulnerable relatives at this time of year who might be frail, at risk of loneliness, at risk of falling, worried about heating and eating and everything that we know that adds to people's burden and health inequalities and the risk of falls and hospital attendance and admission. And we'd welcome any intervention that we can do across our communities, because we care about people who live in this. We're in the business of caring for people, and we care about people who are also not in our hospital walls. We care about people at home, which is why we work hard at turning the ambulances around. Ben, I'll let you talk more on detail. Thanks.
Thank you, and thanks for the questions. I think a few things. The pressure, as David said, the pressure is high everywhere, and I think our growth is greater than the growth at NUH in terms of demand in the last year or so. Co-location, what co-location means is co-located with an emergency department or A&E department. So there is no emergency department or A&E department in Newark, and it's without a whole new hospital on thousands of staff. It's not something that's going to happen. The recommendation for 24 hours to co-locate it to an emergency department is to allow when the patients do present to an emergency department with an urgent or primary care issue, they are sent to the right place and aren't taking up the time of the emergency department staff. So a co-located department is one example. So that's not something that's appropriate for Newark and never would be. In terms of times to be seen, 98% of patients are seen within 4 hours. It's one of the best performing urgent treatment centres in the country. And that hasn't changed, and part of that's how we've reallocated the nursing staff and our ways of working. So times to be seen is good. Regards to travel time, in terms of, again, if it's an urgent thing, there's these things access out of hours, or it can wait till the morning. If it's an emergency, we urge people to call 999 if it's a true emergency. If it's not an emergency, to contact 111, and there's lots of things that can be done there. 111 deals with about 70% of its cases without going anywhere with advice or appointments in the morning. So I'll stop there. Hope that helps.
Chair, could I just add one thing just on 111, because this I'm really keen that we have a a discussion and debate based around the available facts that we have. So I'll just kind of call out a couple of things. One is we specifically asked as part of our listening exercise for feedback on those other ways of accessing urgent care, including 111, and the feedback was majority was positive for 111. And that is what we expected to see, if I'm honest, because when Health Watch England, so an independent body, a couple of years ago did a nationally representative survey, 72% of people, when asked said that they agreed the 111 service gave them a positive experience. So we will all have, won't we, individual experiences of any part of the public sector services where sometimes it's good, sometimes it's bad. But I would urge us to look at the data that is available to us both nationally and that we've collected locally, and be confident in basing our decisions on those facts and that evidence, which all indicates that we have available, all indicates that 111 is an increasingly relied upon and satisfactory service for people. Thank you.
No, thank you, Alex. Good point to raise. And also on our work programme, we're actually discussing 111 on our next meeting, so I think it's really important we can feed that into it and obviously look at more detail then. So thank you very much for that and for the questions, Councillor Welsh. So, Councillor Wilmot.
Thank you very much, Chairman. My first question is it not true that urgent care issues, if not attended to, could soon turn into an emergency situation? That's my first question. I'm also asking you, I'll go back to the opening hours. If someone walks into the hospital and is in pain, and it's an urgent issue, and it's before 9 a.m. or after 10 o'clock, what's the position? Do you send them directly to the emergency hospital in Nottingham, or do you attend to it? It's a question that needs to be asked, because.
Yeah, thank you, Councillor Wilmot. So, Ben, do you want to come in?
Thank you. So, two things. Urgent. Some, not all, urgent conditions can become emergencies, but the demands, but the vast majority do not. So most things, an urgent treatment centre should deal with skin infections, chest infections, people who are wheezing from asthma, sore throat, sore ears, injured wrists, injured fingers, minor injuries, and basically by minor injuries we mean injuries to the arms and legs and that sort of thing. So they don't turn into emergencies. People who have chest infections can get worse, but become very poorly occasionally. But that is something that occurs over several days. You don't go from needing antibiotics for a cough at midnight to being septic at midday. It takes a long time for people who have true minor illness and urgent care needs to turn into what we would advise anyone if they have urgent care needs is to attend at the right time, get it seen and not put it off for several days. The ones we see often that are coming as emergencies are there's a small number, despite treatment having started, get worse, or those that have put off getting treatment who then come in when they're poorly. But if people access the services at the right time, no one goes from being fine to being horribly sick within 12 hours. That's why urgent treatment centre specifications are there, to be open 12 hours a day, because if it's a true urgent need, it won't change from urgent to emergency anywhere near that timescale. And most of the urgent things that will get worse are infections. So as long as people access it in a timely fashion when it is available, there's no risk really of it changing to it. If you have severe chest pain, you should not wait till tomorrow or anything else. You should head to the emergency department, not an urgent treatment centre.
If I could come back on that, Chair. But what I'm more concerned about is the fact that it could be an urgent situation, and the person's in pain, and then that pain suddenly becomes something else, a heart attack caused by a heart attack or something like that issue. I just wondered what your thoughts on that. The NHS England published a new service specification, which you put in your report, for modern UTCs, and that as a priority, UTCs are expected to do as a sustainable model. It's on page 16 if everybody wants to read it. But the question is, are you up to date on these national specifications?
Yep.
Chair, I was going to, maybe Victoria might come in, but Lisa, you want to?
And that was specific requirements of the clinical senate. So that's why we brought the clinical senate in, to assure ourselves that the urgent treatment centre provision from Newark does meet the national specification.
And just to reassure you on the pain thing again, if someone has severe pain or any severe pain anywhere, but pains in their chest, if you have chest pain, we advise you to contact either 111 999 or go to emergency department. Please do not attend urgent treatment centres with anything like chest pain or severe tummy pains or severe headaches. They're the kind of pains that you say turn to a heart attack. So pain that than a heart attack with pain, severe pain in your chest or moderate pain in your chest. Again, I can't stress it. It's really important. If you have chest pain and you're anywhere worried about heart attack, you do not go to an urgent treatment centre. You attend an emergency department, and it's not because the staff aren't great. It's because they don't have the backup and the facilities to treat people for that, and it delays their care urgently. The most important thing is to get to the right place first time.
One more point.
My final question is what the clinical senate response was to your proposals. They're saying that at the end of the day, 1.5 hours was appropriate to see patients that would have got complex issues and so forth, rather than the 30 minutes that you propose. This is what, as it's in the report. I just wondered what you thought about that from the people, as I say, the clinical senate response, who are very, very good at advising, aren't they?
Sure, we're delighted to hear that your view, Councillor Warlock. So, Ben?
Sorry, I missed your other point. We're very aware of the urgent treatment and specifications, and we do meet all of those specifications. I have done for a while. In terms of the 1.5 hours, that is about the time from the last patient arriving and booking in to the staff finishing their shift. So currently it's half an hour. They are advising that it's 1.5 hours from the last patient booking in to the staff leaving, to make sure they've got time to sort out those patients. It's not about all patients. It was referring to the closing time and the staff clocking off time. And that's what we're looking at with the options appraisal, how we can meet that so that staff have got time to see that last patient or last few patients booking in that last half an hour. Gives them an hour and a half to then sort those patients out.
Okay, thank you. Councillor Eddie.
Firstly, thank you for coming back and discussing the findings with us. I've got a couple of points. Firstly, I think because of the number of people who have come back on the engagement, it shows the feeling in Newark and the surrounding areas. And I just wanted to put on record to say thank you to Councillor Sellington, because I know she attended all of the events. And I know I logged on to one of them online, and it was very much about the hours that it was open, and I think that was one of the things that she took away from that. I do still think there's a major confusion regarding A&E and urgent treatment centres, and I think that's one of the major things that I've taken away from today, is the absolute confusion still about where to go and when to go. And looking at your key findings on page 5 of the report, the fact that for Newark UTC to be open 24 hours and or an accident and emergency department really shows the confusion surrounding this. I just wondered what more you could do with the communication of that to try and explain to people the real difference, because I think that to me is the communication seems to be the major issue when it comes to the difference between A&E and the UTC.
Yeah, absolutely. David?
Thanks. I'll have a stab at that, and Alex, as our Director of Communications, might do it far more eloquently than I can, but here goes. So I think over the years, we've mentioned about the national specification for a UTC just. Probably a decade ago, we used to call it an A&E, and that's how it was defined nationally. So when we were at the listening events and people were saying, I just want my A&E back, what they meant was, I want my service that I used to have open and operating. We've never had what we now call an A&E. So you're right, there's a problem with communication and people's understanding of what is what. So just to be really clear, an A&E nowadays, forget what it was before, an A&E these days even doesn't get called A&E. It was casualty when I first started in the NHS 30 years ago. It's now called an emergency department, just to add another layer of confusion for everybody. Is a full-blown, all singing, all dancing, all services, resuscitation room for the most sickest, heart attacks, strokes, road crashes, etc. is a majors trolley area for the very sick who need to be laid down and having urgent treatment, drips, pain relief, and a minor walk-in area for minor injuries and minor illness, and at Kingsmill with the co-located primary care. An urgent treatment centre does not have a resuscitation room. It's as simple as that, because it doesn't have the infrastructure, the backup, or even the scale and capacity in the building to be able to provide a resuscitation service, and neither should it, because of clinical safety reasons that Ben has talked us through this morning. So Ben is absolutely right when he says if you've got severe crushing central chest pain, don't walk into an urgent treatment centre because the backup is simply not there. Stay at home and ring 999. It's the safest thing to do for you. They will then take you to the nearest best centre, so that if you need a clot taken out of your heart at 3 a.m, you're going to be in a centre that's doing that every day, day in, day out, and they do it extremely well. And your outcomes and your recovery, documented, the evidence is there, will be far better for you. It's always better to have it done in a specialist centre, and clearly an urgent treatment centre is not one of those. Urgent treatment centre, put simply, is minor illness, minor injury. Thank you.
Thank you, Lucy.
Yeah, I think as well, in terms of simplifying that message, that is true in or out of hours. So in hours, when urgent treatment centres are open, I think you're right, the message is really simple. If your need is in emergency, phone an ambulance or go to ED, and that is regardless of opening hours for UTC. I just wanted to respond really to Councillor Fold, your direct request of the ICB to make sure that we are really understanding what our populations are telling us. I think the good news for Nottinghamshire ICB, it's a relatively small one in national terms. We serve a population of about 1.2 million. So we stand a better chance, hopefully. And the reason that I come here month after month and actually find coming here really rewarding is so that we can listen to what our population are telling us. And we do make every effort to do that. We don't just do that, hopefully, through the meetings that you might attend. We do that in lots of different ways. But if we're not doing that well enough, we're always willing to get that feedback. And I suppose my major comment really was that our accountability, you're right, is to plan services according to population health need within our available resources. And our main duty is to address health inequalities and improve the overall health of our population. In doing that, we do listen to what our patients want. It isn't a tick box exercise, Councillor Martin. We've all learned a lot actually through this process. I suppose the difficulty is, and we're all patients ourselves as well as what else we do, we sometimes have to listen to what patients want and differentiate that from what they need to improve their health. And I think that is where we are having to hear what patients want from Newark and actually translate that into what they need. And we're not, as Alex said, we're not at the end of that listening journey yet.
Thank you. Welcome, Councillor Wheeler. It's a difficult meeting for you, I probably understand, but I'm sure you're coping with it very well. And also welcome to our visitors today that have come to talk to us. You will be aware, of course, that the previous chairman was very highly involved in this consultation and attended listening events, etc., and discussions one-to-one with you and Councillor Darby. And so I'm a little amazed, to be quite honest with you, that she's not chairing this meeting. It's clear that she didn't relinquish her post willingly, from what was said at the meeting, full council meeting last week. And I have to tell you, Mr. Chair, a recording exists of Councillor Saddington, and I have it here if anybody wants to listen to it. The former chair of this committee castigating the consultation at a recent meeting. She called for the opening hours to be extended beyond your proposals and was highly critical of the listening exercise. She further said that this committee would be voting on your proposals, and we know what she would be saying if she was here. As I said, I'm absolutely astounded at what's happened. It didn't have to happen now. We usually change committee chairs at the AGM in May, and I'm a little suspicious as to why she was removed. And it actually makes a bit of a sham of scrutiny, to be honest, Chair. Thank you.
Well, Councillor, you're completely completely entitled to your opinion. First of all, in terms of recording, first I've heard of that, and I think colleagues want to get some expressions that are the same. So obviously those points I'm sure will be addressed by our guests at the moment. Obviously, as you know, in terms of appointments to this committee, to any committees made by full council, and that was done. So we all here by appointment, and we'll do our job to the best of our ability. But obviously, every council is able to feed in, either through yourselves or sitting here today, like Councillor Girding is, as well, to make their points. And no one is shut out of scrutiny, just the opposite. I really want to encourage everyone to participate, where it's formally in this meeting by discussions outside the meeting that we can carry into it. So, thank you very much. I mean, I don't, in terms of recording, sorry, Alex, you want to come in quickly?
Yeah, thank you, Chair. And it's not for me, and I'm not going to comment on your own decision-making process within the council. I will just pick up on the one point that Councillor Carr made there. No decision has been made on these proposals, nor even has a set of proposals for decision been brought forward. So I just want us to be really clear. And in fact, one of the asks or the recommendations is to understand from this committee what they would like that next stage in the process to be. So yeah, we're really keen to sort of hear what thoughts might be about how we can work together going forward.
Councillor Carr, before I have someone
I'm actually quite prepared to answer that now. Having listened to, and I know you can't, the compounding evidence that Councillor Saddington gave as to why you should be increasing hours and why she doesn't agree with the consultation has been listened to and properly, are enough for me to say that we should go back and say, no, we're not happy with this consultation, we're not happy with its outcomes, and I'm ever so sorry, but I'm perhaps a bit of a cynic as I've been a councillor for 20 years now. I've come to the opinion over the years that consultations don't start unless somebody's made their mind up somewhere. Thank you.
I think we have to clarify there's no consultation so far. It's been a listening exercise, and that's what we have to really clarify on the conversation. I hope so we make sure that's in the record so far. And obviously, any consultation goes forward, that will be decided when we come back there. So we have to be clear.
The chair is very unhappy with that.
Well, obviously, not in the room to defend or to those comments. So I think it's absolutely clear. We just need to make that. It's been very much made clear by the ICB, by the colleagues in the room, who are obviously with absolutely no reason at all to distrust that at all. That decision not been made. They're here to listen to our opinion, as there will be to residents, and we, as I say, when we come to the end, we'll be able to obviously submit more comments and put our recommendations forward. If it's actually about the agenda, I'll take more on this. I'm really conscious I want to get around to the other colleagues who can speak. So, Councillor Welsh, if it's.
I was just going to say we need to be really careful that we don't make people that are visiting here from an organisation feel difficult about a decision that was made by the leader of this council, not on my side, by the way. I didn't think it.
Couldn't agree more, Councillor.
I think that's really important that we don't do this. What I would say, Councillor Reader, is what has been pointed out is that Councillor Saddington has done a lot of background work with regards to this and been involved. If you haven't already met her directly relating to this, could I ask that you do it as a chair as soon as possible? So actually what that does is that precedes some of what maybe of Councillor Carr's concern, that you actually hear it from herself because she does have that wealth of experience with regards to it, and she does have that local knowledge, and I think it would be a disservice to the people of Nottinghamshire if you don't capture that as a chair going forward. I've already put online my disappointment with regards to it, but I'm also a firm believer in health scrutiny, and I think this is very, very important for the people of Newark and for the future of Sherwood Forest Hospitals Trust and how they operate this winter. So if I could ask that happens, if it's not already happened, I think that would be very, very useful, and then we avoid this situation where you can actually feed back. As I said, she's had a wealth of it and been very personally involved with regards to it, and I think that would be very useful for us as a committee to capture that, if that's okay. And again, it's just having that thing, I'm saying you're visitors, but they are from a different organisation. We're not here to bring up that in front of them.
Yeah, no, Councillor, I think it makes a good point. Just to be absolutely clear, I have had a discussion with Councillor Saddington, and obviously we'll continue going forward. And of course, as I said to you, I spent most of my evenings since the appointment listening back to recordings, and obviously not only that, having discussions with colleagues in ICB and NHS as well offline about this, as well as obviously with my vice chairman here has been in all this discussion as well. So I'm just giving my assurance, going to absolutely make sure I got all the background information. So just conscious that there are any other speakers on the from the meeting before I bring Councillor Gurley. Because he's indicated to speak as a local member before the meeting
Councillor
approached me.
Girling is a member of Cabinet.
Yes, I absolutely.
Well, then you should have given other councillors the chance, like Councillor Darby. You should have given patient groups and health unions the chance to address it. I object to a Cabinet member addressing a scrutiny committee. Whether he's a local member or not, he should have fed in through his own members of this committee, and I wanted it recorded in the minutes that if he speaks, it is against protocol and it is against the Constitution when it relates to scrutiny committees.
Okay, well, I'll take the advice in terms of as Cabinet member, but my understanding is Councillor Gurley, with the conversation we had, was just going about as one member, making absolutely no reference to his other roles he has within the council, which is what we agreed beforehand. But I just want to make sure we agree with that now. Yeah.
That's my understanding, that he can speak as a divisional councillor affected by what's going on.
Okay, before I bring Councillor Gurley, Councillor Martin, so I didn't see your hand up. Is it something different to what we discussed already?
As far as the next steps go, would it be possible for you to come back and tell us what you plan to do, the change of hours? Because obviously you're still talking about opening 12 hours, so where are you going to go with it? Are you going to go to the end of the day or earlier on? Because what you've said is that you haven't got enough staff to expand it. So I hear that, and I agree with the sentiment of it, because obviously you've got stretched times during the day. So that would be my, from your point of view, despite this, you could come back and tell us what you actually plan to do as a result of the conflagration of the Senate and the public consultation listening device, whatever it was.
Yes, I think that's absolutely right, Councillor Martin, and that's our last recommendation, actually, to ask how you would like to receive further updates, what would be useful for you. We recognise that you are all a significant part of ensuring that your public's views are heard. So I think that's for you as a committee to conclude at the end of today's discussion how you would like to get further updates from us. And to reiterate, we haven't done statutory public consultation.
Any other committee wish to speak? Okay, so as we've been agreed as to the Constitution, as a divisional member representative, Councillor Gurley,
point of order, Mr. Chairman. Can we ask for a ruling from the monitoring officer, please, on the Constitution relating to this matter, as you are giving Cabinet member the rights to address a public meeting and a scrutiny meeting when we haven't asked other people that may have wanted to contribute to this meeting and haven't been given the opportunity to consult this meeting. I know Councillor Gurley is a Newark member, but there are other people who are Newark members who aren't here, probably weren't aware that they could address this meeting, and that is highly unfair and irregular. So I would ask that we take advice from the monitoring officer before Councillor Gurley is listened to. Thank you. I'm sorry to put you through this embarrassment, but this is highly irregular what's being asked.
Well, Councillor, it's highly irregular. It's always been standard, as been indicated to me, that there's an overall policy for councillors of the division members who can speak if they wish to. And I say the only person who has contacted me who expressed this agenda has been out in the public domain for over a week. The only councillor was Councillor Gurley. So when you say other officers, other councillors, no one else has made that approach.
Well, I'll come back to you on that when they're probably not aware that they can, because we've got people who are appointed. We've got councillors who are appointed to this committee.
Absolutely, and it should be worth saying that Councillor Gurley, if we invite him to speak, won't have any say over the recommendations before us today. It's
Well,
to give
I
a speak
don't
on
think
behind
he
it.
should be heard. I repeat my request that you consult the monitoring officer over the constitutional legality of a cabinet member addressing a scrutiny committee when other people haven't been invited to do so. Something until we get the monitoring officer ruling.
As far as I'm concerned, cabinet members do speak at scrutiny committees. They are invited to speak on other items. So I'm going to allow Councillor Gurley to speak. No, I take your notice.
Cabinet members speak at committee when it is their scrutiny role. That Councillor Gurley's economic development and asset management is absolutely nothing to do with health.
But that's entirely your point there. Councillor Gurley, as I've already made clear before
highly irregular.
If to speak as a member of Newark representing residents.
This is highly irregular,
well,
Chairman.
It's highly irregular, but I'm going
we will be writing to the monitoring officer about this.
That's entirely your prerogative, Councillor Carl. So I'm going to Brighton now there. So, Councillor Gurley.
Yeah, thank you, Jim. I'm sorry it's causing so much hassle. I'm speaking on a couple of hats on, really. Firstly, as the actual hospital comes in my division, so I am the local councillor, but I'm also speaking as a resident of Newark that's had the misfortune, if you like, to have to use the urgent care centre. And also, because I heard something about 111, health's not been as good as it should be recently, and I've had to use 111 quite a few times recently as well. And I've always found it to be very efficient, and actually within 15 minutes of me calling 111, there was an ambulance outside my door, which actually raised my anxiety a bit because it was this quick, to be fair. So from that point of view, I was actually used the urgent care centre because I broke my leg in two places, and the reassuring thing knowing was that it was going to be open. One of the things I wouldn't want to have happened is when I broke my leg, not knowing if it was going to be open or not because they couldn't staff it. So that's from a personal level, that knowing it's going to be open, I could go there, be treated, and then they dealt with it really well, and the staff was absolutely fantastic, and I did the feedback, so I'm probably one of the feedbacks that you've had. So that was reassuring, and it was also reassuring to Councillor Martin say that you can get from the far side of Ashfield to the King's Mill in the same time as you can from Newark to King's Mill. I don't know where to get an hour from. I've lived in Newark for 30 odd years now, and it's never took me an hour to get to Mansfield ever. And an ambulance gets there a lot quicker anyway. So to me, knowing it's going to be open and it's properly staffed is the most important thing. And when I speak to people about it, that's what they would prefer. Now, of course, if you ask anybody, do they want it to be open 24 hours? Absolutely, yeah. If you ask the people of Newark, do we want to have a full-blown hospital there like King's Mill, I can guarantee you'll get 99% saying yes. So, you know, and they can understand that. But that's part of it. And my chest pains, obviously, there's no way on God's earth I'd have gone to the urgent care centre with that. So I just wanted to make that point, really. No matter which way you go, it's about making sure and that there isn't that uncertainty about, that people know exactly what they're getting from that hospital. And I've seen over the time I've lived in Newark, all the different services that are now being put there. I mean, I went for a scan the other day because I'm talking about my own health now, and there's lots of things. So, everything I've needed has been there once I've been to King's Mill. So it's great. So, yes, would we like a new hospital? Absolutely. But really, from a realistic, practical point of view, just let us know when it's going to be open and make sure that it is open in them times and that I've got the right amount of staff there to look after the people that need to be there. Thank you.
Thank you. Was any come back on the points? No. Okay, thank you. I think it's worth we are now to recap in terms of what's said today. For me, the key thing is communication, and that's not just saying that with Alex in the room there in his role, but I think we've already identified there are substantial issues in terms of the communication, what residents expect to have at Newark Hospital, and if we've got concerns or questions asked within the room here, then I can only imagine what some residents are asking. And I've looked at some information online and some stuff that's been put forward by local councillors in the area, and some of the comments on things like your page, Newark Appetite, etc. And there is a lot of confusion. I think you've raised about A&E in the past, but we have to be conscious of the fact that people's terminologies might still be what they used to and grew up with. So I think from what we heard today, my plea would be whatever communication goes forward with residents, it's made absolutely clear what exactly urgent centres for, the times, or also to be exact specific on where else they can get those services, because it's, like I say, just to recap that, very much clear. I think that we've got some work to do to reassure residents there. And I'm sure we have in other areas as well, but especially in Newark, based on what we've been hearing. In terms of that, so the recap from me on those points, and what the committee have asked to say is an update. So when you have made your decision, I think in terms of getting that reckoning, but the decision come back to us in terms of rationale why, which we'll either address in a item here or a briefing note to councillors and decide if we want to obviously look at that in further detail. I'm very conscious that we have already in depth now, but like I say, what I plea would be, like I say, taking part of the comments you've had from the group today. I think it's been quite substantive, already made not only today, but in terms of the other meetings we've had so far on these items, and to really keep listening to the feedback you've had from the residents so far. So, has anyone else got any questions before we get to recommendations? No, sorry.
Can I just ask, just for a bit of guidance for the committee's benefit, as to your scheduling of consideration of this, and whether it would be in the public setting, in order that we can gauge how we manage our work programme from the point of view of whether and when the timescales for this coming back.
Victoria, may be better to comment on precise timescales, but I think we will be ready to come back again in January with the outcomes of our options appraisal, and it is ultimately the ICB's decision about how it commissions services, and we would want that to be entirely transparent, so we would come back in the January meeting. That's right, is it, Victoria?
Yeah, that's our current scheduling, Lucy. Yes.
Okay, we'll look at that. Of course, we have a work programme for January, so we'll see whether it be January or whether it be March. To obviously, because also to see how the impact has been after it's obviously been announced by yourselves, and what the feedback is from the public. So we'll discuss that when we get to our work programme item. But thank you very much for that. So for the committee, sorry.
We as an ICB won't be making any decisions publicly until we've been back to talk to you. So we can come. Yeah.
Okay, no, thank you. That's useful. So the recommendations in front of us are, to recap, to note the findings of listening exercise, which I think we have done in a lot of detail. Note the feedback from the Hill Senate, which again has been noted so far with the committee. Note the outcomes of the options appraisal, which again we have, and to consider next steps and actions, which I think we've done in great detail. So with the caveat there that we will look to bring this back to scrutinise what decisions made, which we'll cover when we get to the work programme in more detail. Can I have a show of hands in support of the recommendation? Sorry, Councillor Folk.
Can I just say, I think it's really important that when we get, because these are very big documents, aren't they? They're very big documents. I think it's really important that when you do come back in January, we really hear that actually people, the public out there, have been heard. And I mean, we constantly talk about health inequalities as well. Health inequalities are massive now. It is a really, really difficult, very troubling situation that we're in, and they're getting wider. So I would like to see those. Oh dear. Oh, crikey. Is he all right? Okay.
Who's the doctor?
Yeah, any doctor.
Okay. So just okay. Okay, it's Councillor Pole.
So if we could have that fed into the recommendations, that those two things are absolutely paramount in terms of health inequality and in terms of kind of listening to the people, what people really require. Make sure that they really are high up in the priority. Okay.
Yeah.
If that is in the recommendations, we're happy to vote for it.
Okay, thank you. No, I think absolutely it's noted, and I'd say I know that the team of the HRC have noted that as well, and we'll obviously sort of take that feedback on board as well, that we just made that today. Any comments you want to make on Councillor Paul's point before we vote? No.
The decision we make will give due regard to health inequalities, impact on health inequalities, so we will provide that evidence.
So that evidence will be provided, so that's fantastic, thank you. So if we go to the vote then on the recommendation, all those in favour? So that's unanimous, thank you very much, and thank you for reporting that this morning. So we move on to the next substantial item in the agenda, which is the tomorrow NUH. So
just have a brief pause.
Yeah. So just have a quick pause before we recheck the running order of the people. So back in 2 moments. item, which is item 5. So this is the tomorrow's NUH proposal to consult. So again, I know this has come before the committee before in great detail. So what we are here today is to obviously get the update on the pre-consultation business case, the consultation document, and the plan for consultation on tomorrow's NUH. So a bit of shuffling around on the chairs. So we've still got Lucy with us and Alex, and so thank you for staying. And we've got Mark Ryman, we've got Phil Britt, and we've got Dr. Anna Harkham. So welcome to the committee. So we'll go straight into the item itself. So who's kicking off? Is it Alex? There you go again. Thanks, Alex.
Yeah, apologies, councillors. It's me again. So just to remind council colleagues, we're here to follow up from the October meeting, as the chair has said, where the committee agreed in principle to consent to a public consultation on the tomorrow's NUH proposals, subject to the board of the Integrated Care Board's final approval. And we also said we would come back to this meeting to discuss some questions that you had in more detail and also share with you all of the appropriate documents. So today we're going to do 2-3 things. We're just going to remind you via Mark the sort of content of the proposals that are made up by tomorrow's NUH. And then I'll describe again in a high level what the consultation plan looks like, and then look to answer your specific questions from last time. And again, to remind you, we have provided you with the consultation document, the consultation plan, and a copy of the full pre-consultation business case. There'll be a short quiz on the full content of the pre-consultation business case, so I hope everyone is ready for that. Mark, do you want to take us through the overview of the programme, please?
So shall I start with the page 1 of the PCBC, and we'll gradually work our way through to page 348. I'm not going to do that clearly, you'll be pleased to know. So I'll just take a bit of context. So in fact, Councillor Martin, you referred to it earlier, part of the government's pledge back in 2019 was to build 40 new hospitals by 2030. And Nottingham University Hospitals are in the very lucky position of being one of the chosen few. When I say one of the chosen few, there are about 128 acute hospital trusts in the country. 40 of those are going to get investment, and Nottingham is going to get a very significant amount of investment, all of which we hope is good news. The role of NUH, people like Phil, Anne and myself and the colleagues in the ICB, has been to develop the business case, the pre-consultation business case for the reconfiguration of Nottingham's hospitals. That's been going on for the last 3 years now, and you've got a copy of that in your packs. All of that work and planning comes together in the PCBC, and our role as the Integrated Care Board is then to put that in front of the public. So this idea of no decision about me without me extends to reconfiguration of hospitals, and the role of the PCBC is to show to the public, our stakeholders and partners, that the plans we've developed over the last 3 years are deliverable, affordable, and most crucially meet the needs of patient public stakeholders now and in the foreseeable future. So that's what the pre-consultation business case is all about. And as I've said, the point of writing it, and there's a clue in the name, the pre-consultation bit, is that it's there for the public to digest. Now, clearly the public are not going to go through 300 odd pages of business case, and hence you've also got in your packs the kind of the reader-friendly version of it, which seeks to pull out the high notes of what we're seeking to achieve. So that's the background, and I'll just give you, speaking of high notes, some of the key elements of the scheme itself, so we know what it is we're talking about. Chair, I can see that. Did you? Oh, okay. So the key elements of the scheme itself are, number 1, consolidating women's and children's services in a brand new facility at Queen's Medical Centre, and that will create the first integrated women's and children's hospital in the East Midlands. Point number 2 is consolidating most emergency care at QMC, excuse me, in line with its status as a major trauma centre. And at the same time, the quid pro quo of that is consolidating most elective services at City Hospital. And that separation of elective and emergency care is really crucial to the clinical model for NUH, and actually is what the NHS is trying to do up and down the country. You will know, no doubt, through your kind of sitting in this committee, that those trusts that have managed to separate elective and emergency care have done better at eating the backlog post-COVID, and going into COVID have had shorter elective waiting lists. largely as a consequence of when emergencies are running hot, which is now all year, let's be honest, then they don't knock out elective care because they're taking over theatres and inpatient beds. So that split is really important. And then the final kind of major component of the scheme is the creation of a 2-site cancer centre of excellence, with most of the surgery at City Hospital, so it's protected in the same way elective surgery is, and the cancer treatment, the medical treatment of cancer patients, located at Queen's alongside the medical specialities. And if you've read the packs, then you'll see that was a kind of a major consideration of the clinical senate when they put a slide rule over the NUH plans. Last thing I'll say, and then I'll hand over to Alex to talk you through the approach to consultation and engagement, is, as you'll also no doubt have heard, the headline of 2019, 40 new hospitals by 2030, has been nuanced in the last 8 months, largely as a consequence of the potential structural failure of some hospitals that were built during the 60s and 70s using this thing called RAC, reinforced aerated autoclave concrete. I think essentially it's like an aero bar and has the same kind of structural integrity after about 30 years. So those trusts have kind of leapt forward in the queue for reconfiguration investment, and as a consequence some trusts have been slipped, so no longer completing their work by 2030, maybe starting it before 2030 but completing it after 2030, and NUH is one of those schemes. It's not what the trust or indeed the ICB wanted to hear, but it's the right thing to do in terms of some of these hospitals who have even more pressing need. So that's essentially the scheme. There's a lot of work to do between now and 2030, or whenever the work starts, outline business cases, full business cases. So at least as much work to do as has been done, but we're in perhaps the reasonably lucky position that we are one of those trusts and health systems that could significantly benefit from a great deal of capital investment in our hospitals. Alex, shall I end there and over to you?
Thank you, Mark. So next slide, please. So you've got in your papers a copy of the consultation plan, which we gave you an outline of last time. That's Appendix 2. And in summary, set out on the slide, the consultation is about explaining what these proposals are to our population and gathering their feedback on it, as well as ensuring we're demonstrating that we're doing all of that and meeting our statutory duties and developing an audit trail. This is a big deal, both in financial terms and in length of time it's going to impact people. We are proposing a number of changes, and therefore we have to be really sure that we're getting that right and that we're documenting how we've developed and agreed to those proposals. So that's why we're looking to go to consultation on this. So on the next slide, this sets out some of the things that we're going to do. This is about us hearing from as broad a range of our population as possible. In particular, I'd highlight we're intending to produce all of our materials in the top 5 languages other than English that's spoken in our patch, as well as in an easy read format. And throughout the period of the consultation, we'll be monitoring the demographics of respondents and make sure we're correcting our activities so that we hear from as representative a sample as possible. Also, as a matter of course, we're going to deploy a series of best practice interventions, offering a blend of online, face-to-face, telephone response mechanisms, as well as ensuring any public meetings are accessible. We're offering translators, interpreters, hearing loops. We are determined that there are no barriers to anyone in any of our communities, any of our population coming forward and giving us their thoughts on this. And indeed, we'll go a bit further than that as well, certainly geographically. This consultation will touch on residents outside of Nottingham and Nottinghamshire. We know that services at NUH are accessed by residents all across the Midlands and even broader. So we're going to make sure that we hear from not just our 1.2 million population in Nottingham and Nottinghamshire, but those who live in the borders, into Lincolnshire and Derbyshire and Leicestershire, and further afield as well. The next slide sets out some of the main ways that we'll be reaching residents. The most important ways, I think I've already said today and pretty much every committee in the last few years, we are going to do this by going to where citizens already are, i.e. go and access them in their everyday lives, be that their social groups, their workplaces, their interest groups, their community activities. We want to hear from people on their terms rather than and on their turf, rather than expecting them to come to us. That's probably the most important way that we will gather input into our proposals. Alongside that, we're planning to run a number of sort of set piece meetings and interactions, particularly some specific interest sessions on particular topics. That might be a thematic session on mental health or maternity or green and carbon issues, so that we can hear people on those kind of cross-cutting themes. Excuse me. And we will also run a number of public meetings across the generality of the proposals, so that someone who might be interested in a little bit of everything can come along and have their say as well. And all of that will be backed up by a survey that's available online, in paper, on the telephone, so that people can feed in their thoughts in the way that's most convenient for them. So those two slides just give you a kind of a summary of the full consultation plan which you have in your pack. You asked last time as a committee a number of questions, so we've responded to those. We've set those out in the covering paper, and so I'll just kind of bring those to life. They're in section 4 of the paper. There was a specific question around, we talked about this a lot, the proposal to bring together Women's, Children's and Family Service into a single new build facility. And you had a specific question around how would that work? In particular, how would female fertility services be housed in the same building sensitively? And we absolutely recognise that this is a really sensitive topic that we need to get right. So in the consultation document at section 12.2, you can see how we will approach that. It is worth noting that fertility services are not proposed to be included in the new Women's, Children's and Family Services building. A whoop of excitement from Councillor Welsh, thank you. That said, I think we're still acutely aware that the sensitivities that exist are bringing together that cluster of services. We've got to get that right. We're going to really concentrate on sensitively exploring that and making sure we've not missed a single angle on getting that right. Because this is a big win. Getting together a state-of-the-art service for women, children, families is a real win. We don't want to sort of stumble and miss something or inadvertently get something not quite right. So, a commitment there that we're going to do that. Secondly, you asked us to really think carefully about the city hospital and the long-standing expectations of local communities about giving birth at that hospital. And I want to stress again, we're really aware of that dynamic, and we've done a lot of listening already for that sort of populations around the city hospital. And you can see in the papers an extensive stakeholder mapping exercise we've done. We've refreshed that continuously through the 2 phases of engagement we've done so far, and we're going to carry on doing that. So we've identified a number of different communities that we will want to reach and set out the bespoke ways of doing that, and again that's set out in the consultation plan. You asked a more general question about ensuring that a broad range of citizens are heard from as possible, as broad a range as possible. And again, in section 3.4, we set out the different methods that we will use to engage with citizens and stakeholders. And the full consultation document, as I've already mentioned, will be available in easy read format, top 5 languages, and a version that's for people who have a lower level of literacy will also be produced. And we're also going to do a number of other things. You know, there'll be videos, there'll be different materials so that people can access this content in whatever way works best for them. And as I've mentioned, translators and interpreters will be available both proactively and on request. And finally, you asked a specific question, because we talked last time around the proposals of that potential vacation. There is, of course, a consideration. So, final slide from me. What we're asking for the committee to do today is to note that full pre-consultation business case, the consultation plan and the consultation document, which we've now provided for you and are published for anyone to look at. Also, and ask that you note those specific responses to your questions from last time. And finally, confirm, please, as a committee, if you would, that you have no objections to the Integrated Care Board proceeding to public consultation should it wish to do so. That is not a decision that the Integrated Care Board has yet made, but the board will want to know whether or not you are content for that to happen as part of their decision making for that process. Thank you, Chair.
Thank you very much, Alex, for the presentation. I think you're not behind anyone who's going to be against investment in our hospitals. I think, I would wager on that one. But you're quite right. What's really important is to make sure we do it sensitive in terms of make sure the service is in the right place. Because this is the golden chance to rejig around there. We've got to make sure we don't put a sour note on potential investment, but also potentially put people off visiting our hospitals, because obviously it's absolutely not what we want to do. So, looking for the report, like I say, is very weighty now, like I say, in terms of paper there. I think we get told off by our print room after we put that through the printer, but there we go.
They loved it.
Yeah, well, they probably did love it, actually, yeah, but not, we've got to make sure it's having that going forward. But, in terms of the recommendation in front of us, thank you very much, Alex, for reading them out. They are in our papers, as noted there on the presentation. So, before I come in with my bits afterwards, open up to the floor. And Councillor Martin got in very early as always again, so over to you.
Yeah, thank you, Chair. Obviously, I did allude to the fact that the government said they were going to build 40 hospitals, and so far we've only built 2. So that brings me to another question, because obviously it's a hefty piece of work. We know that, Alex, and it's complex. It's a myriad of services, and it's going to take a long time. So timelines obviously distorted by RAC, obviously for reasons, to be cheerful, changing different buildings and realigning the timeline. I just want to know really what assurances we've got from the government on the longevity of the plan, because the investment and the actual process is not sure by any means, is it? Nothing is with NHS. We're talking about 2030 onwards. That's 6 years away. So I just want to make sure heavily and put all this effort into changing the services of NUH vastly, that we've got the assurance that the money's going to be coming. And equally, if it's not going to be coming, is there a plan B? Thank you, Chair.
No, thank you for that, Mr. Martin. Lisa?
What I would say is, for the Nottingham hospitals, there isn't a do-nothing option, as you know. Queen's was built sort of over the 1970s. That's an awfully long time ago now. And City Hospital arose from sort of workhouses in the 1880s. So whatever happens, Councillor Martin, any commissioner sitting where I'm sitting, any provider sitting where colleagues from the trust are sitting, will make sure that we are able to invest in those hospitals. What we've been doing is, as you do for many years now, replacing and repairing. But there are parts now that need. We've been repairing. There are parts now that need replacing. And when you talk about replacing, you talk about replacing according to models of care that are more current. So I think short answer to your question is I can say with absolute certainty that there would be no likelihood that the local NHS would not invest in Nottingham acute hospitals. This is our optimal plan, and this is the plan that we have as well assured as we can be. And we have had some conversations more recently with the new hospitals programme. Will sustain electoral cycles. Now, you never know, do you? But it's been made really clear to us that, the need is understood, the money is available, and the only thing that could, it's a priority order thing potentially now, the only thing that could take us out of our priority order is something catastrophic happening to another hospital. So, that is the assurance that we've had. The unforeseen can happen. If the unforeseen could happen, as I say, we would try and implement this plan in a different way.
Okay, thank you very much, Lucy. So it was photo finished. I think Councillor Welsh, you just got from to Councillor Folt, so with your hand to go up. So, well, if you want, I'll say if you want to. That's not it to you, Councillor. Don't worry, I'll say it to you, Councillor. So you'll get trouble, Councillor Welsh.
Thank you. I'm just going to focus really on the women's health. There is something I think quite exciting and quite forward thinking with regards to it. I think the idea of having consultants, nurses, hospital staff concentrating on women and children's health in one area, there's something quite exciting and quite forward thinking with regards to that. So I will place that on record. I have made it known in the past, and Alex knows this. I do have an overall concern about, given the state of maternity services and the continued state that it is, about tinkering around with it when it is in such a poor state and continues to be in a poor state. So I am going to allude to some things that are in this bigger report with regards to maternity that have caused me concern, including some of the language that has been used, which I thought we'd moved away from as an NUH. I really did think we'd moved away from that kind of language use with regards to maternity services, the Donna Rockington review and what was going on. So page 140 of the committee paper says, I'm going to ask my questions as I go along if that's okay, that the developing proposals for family care are carefully managed alongside the work currently taking place to improve maternity services and the Ockenden review. So here's the thing. We know that Donna Rockington comes back to NUH, and when something alarming comes on and goes straight to Anthony May and things are put in place immediately. My question is, and my suggestion is, isn't there a clear risk that you're developing proposals which in the end would be at odds with the recommendations put forward by the Ockenden review? And the reason that I say this is the biggest maternity crisis in the NHS has ever seen. It's huge. You know, I have regular meetings with families, and part of it all, I couldn't even tell you, and I'm sure Donna can't even tell you what some of those recommendations are going to be and what the actual outcome is with regards to that. So I have really serious concerns about developing something before the results come out of that Donna Rockington review. Serious things. And with that in mind, if you carry on doing what you're doing and the recommendations aren't in line for what you're proposing, would you be prepared to change that? That's my first. Page 461 under risks heading, the Ockenden review is acknowledged as mitigation. And it says, this is a bit what I'm a bit, ensure the programme momentum is maintained while being pragmatic and courteous to the review, ensuring appropriate messaging is developed with the review team as part of the public consultation. To me, this strikes me as we're going to get on with it, irrespective of the findings of the reviews. For me, that mitigation should also include be prepared to modify the programme based on the recommendations of the review, and therefore you'll need to consider proposed changes if you're going to make any. That has to be there within the mitigation and very, very clear. And then page 505, the review report is due to be published by September. This is the Ockenden review. It's due to be published by September 2025, and the findings will be fully reflected as appropriate in the future planning for maternity services. Now, I don't think that's a good use of language. I think it purports to not having enough seriousness with regards to that review as appropriate. Okay, I'm a comms person. Maybe that's why I'm looking at it in a certain way, but I don't think that is.
Councillor, sorry, you've only made 2 points, 2 big points so far. Can they come back on those 2 points, and we'll come back to the rest of them? Yeah. Please do.
So, Councillor Welsh, as ever, your input is extraordinarily helpful, and if that is how you are reading it, that is how members of the public will read it. So we will, and as you say, language is really, really important, so we will give due regard. I think your point of principle, that is exactly where we as the Commissioner are, both in supporting tomorrow's NUH and ensuring that the lessons are learned from Ockenden, and that we want to proceed in general to maintain the momentum around tomorrow's NUH, but we will ensure, not may ensure, we will ensure that recommendations are incorporated in this service proposal. We have had that conversation actually as an integrated care board about pace and time and when the right time is. So the request today is to be allowed to go to public consultation at a time that is appropriate. We will, and don't forget, public consultation is just the start. You go to consultation, so that will take a period of time. We will hear from the public. The Ockenden review will be maturing. The findings will be being heard. You know, we will take account of those. So it is an iterative process. So I think what I wanted to say to you, that is exactly the process that we will follow. And there is no chance that we would do a kind of once in a lifetime reconfiguration of our services and our facilities without making sure that all of the lessons learned are incorporated. So it's not a kind of an either or, it's a proceeding with the two together. And I'm sure we'll be back here many times over the period of time to talk to you about both of those issues. But I think your points around language are really, really helpful because we can reflect that.
Yeah, and I do think it's really important that language is very, very explicit because there is a trust issue from people with regards to maternity services, as you'll know. So being absolutely explicit that you are going to treat this with seriousness, that's the kind of language we need to listen in this documentation if we're talking about tomorrow's NUH, because that reflects that there has been some learning from the trust with regards to what has happened. And when I read this, it doesn't reflect that there's been some learning. It reflects some very old attitudes. It really does, and that does need to change and be clearly reflected in this documentation. And I'll go back, and this is my last point. Sorry, Chair, but I do think this is really important. Page 266 of 540 on your report. It mentions the Ockenden report in Shrewsbury. Well, you know it's Shrewsbury because you have to read the fine print underneath. And it's a really bizarre, out of all of that report, and I've read that review, and I've met with some of the people that have gone through horrendous situations in Shrewsbury, and it's a really bizarre paragraph for you to use as a trust, because you've chosen a paragraph in a report which is hundreds of pages long that says, the independent review of maternity services found patterns of repeated poor care and failure in government and leadership that led to cases of harm and deaths of mothers. These incidents were not seen to be unique to a single trust and have been highlighted in other national reports over recent years. Now, you have to understand how someone was reading that would reflect on what your attitude is to what has happened in maternity by using that paragraph. Yes, there is huge issues across the country with regards to maternity services. That paragraph has been taken out very out of context throughout the rest of the report with regards to Shrewsbury and Telford. And quite frankly, if any of the families in maternity services had a bad deal would read that, it is offensive. Every single case in Shrewsbury was unique. Every single case. There were patterns, of course there were patterns, as there are going to be patterns in NUH, but I find it really, really bizarre and actually unacceptable that of all the paragraphs out of that report, NUH has decided to use that paragraph. And this is why I hope you understand, from someone that's lived and breathed this situation with maternity services, you've shot yourself in the foot slightly. Because I was here and ready to come here today to say how absolutely fantastic it is going to be to have a women's health focus, how absolutely forward-thinking, which I did in the past. But I'm going away again worried about actually how this is going to pan out. One, because to me, it doesn't feel right from what is... If I read this report and hadn't spoken to you, it doesn't look like you're streamlining it against the Ockenden report from what the language has been used. And there's still this language being used of it happens in other hospitals. We should not be doing that anymore. We should not be using that. And as I said, out of hundreds of pages from the Shelford, that was the wrong paragraph to use. And I'm not even sure why it's in there. I don't even know why it's in there. If it's trying to say it's happened in Shrewsbury and it's happening in Nottingham and it's really similar, it's not. They are two very different reviews with two very different things that are happening. So this paragraph either needs to come out and there needs to be an explanation, because I don't understand what it brings to the report, and I don't understand why it was there. I know how I feel it could be there, and if it is there, then that's not acceptable.
Thanks, Councillor Walsh. Do you want to come in, please?
Yeah, so apologies again, no offence intended at all. So, and if it reads like that to you, then it will read like that to other people. So we really will take that on board. You will see the document is in draft. There are opportunities to amend the document up until, that kind of language. So we will take account of that, and it's certainly not meant to cause offence, Councillor Walsh. So I can only apologise. I think the reason that we're here today is not necessarily to ask you to sign this specific document off, although if it were to change considerably, that would put us into some different process, but to just get your acceptance that the changes expected as a consequence of this are substantive and therefore most certainly do need public consultation. But we can talk through how we make the documentation absolutely appropriate for all the audiences that will see it, can't we, Alex? That's
absolutely. Yeah, I think the key point, as we saw before, Councillor Walsh spoke, is you've got a fantastic opportunity here in terms of what they're around the hospital and investment, and what we don't want is any negative connotations by looking at reports of what might potentially be happening. So, from the feedback on board, Councillor Walsh and our committee members, we can get addressed. Like I say, not just we want to obviously show, which I'm sure has happened, learnings have happened so far, but again, not to distract away from what wanting to go forward. So, thank you for raising those points, Councillor Wells.
I think, Councillor Welsh, for the purpose of the pre-consultation business case, it's reassuring to hear that you support the general principle of how we want to approach women's and family services, and that but obviously the articulation of that to the public has to be sensitive.
It's, as we said before, the previous item, communication is key, isn't it? Like I say, it could roll without shouting, which would be really unfortunate that was happen, just if it's not. So just got kind of clarification, Councillor Walsh.
Yeah, just to come back from that, I fully support anything that advocates better health for women and babies. It's why I'm sat here today. I just need those reassurances that you are consulting on something that is going to make those services better, and you're going into it having learned from mistakes in the past. That's a be all and an end all of it. Thank you.
No, we've had this point painted after Lucy said that has happened. I'm sure that reflects the final report, so thank you for that. So, Councillor Paul next and Councillor Carr afterwards.
Yeah, thank you, Michelle, and thank you for that reassurance. That's really helpful. I think the language that's used is actually a really good point to make here, because I have to say that sometimes when you read kind of huge documents like that, when you present them to people like us, actually, we're kind of scouring all the way around to actually find actually what we think is kind of the nub of the argument, and sometimes it's quite hard to find. So some of the cynical ones among us, and not necessarily me, will think, well, actually, sometimes we try and bury things in a report that actually key things aren't always drawn out. So a bit more of the key things being drawn out would be actually quite helpful to us, I think. Would be very helpful to us. So I just picked on one or two, because I'm interested in two things. First is, as I've already said, around health inequalities, because there's a lot of talk about health inequalities in this report, but like a lot of things, I'm not seeing much link between the health inequalities and actually what happens next. I don't see that, and I would like to see that thread more firmly kind of glued together. I'm looking at paragraph 161 in terms of integrated model of care. Our current clinical model is ill-equipped to meet the needs of an ageing population, the proliferation of long-term conditions, and health inequalities across Nottingham and Nottinghamshire. Just putting health inequalities in a paragraph doesn't make anything happen, does it? And I know it's hard, and I know you're doing a really good job, but I want to say that. So this is great, but it needs resourcing properly. And just to go back to kind of the hospital kind of promise kind of here, it's already been alluded to, this QMC and City Hospital, both were included in Conservative government pledge to build 40 new hospitals by 2030. But in May, the government's now said that now the project will be finished before the end of the decade, which is 7 years away. And again, this is going to sound party political. Well, I'm sorry about this, but the government is making a lot of promises, but not delivering on a lot. And I think that's a real concern. And I like your confidence in that it's kind of going to happen. I get that, but I'm dubious as to actually really whether it's going to be. And I just wonder if. And I think we can all put pressure. I mean, certainly Michelle and I will be putting pressure on our front bench to make sure that all these promises are being delivered. Rest assured, we're doing that all the while across a whole range of kind of stuff that's kind of being put together at the moment. I'd just like to say a quick kind of parochial one as well. There was talk at one point of a hospital ending up in Broxton, which is actually where I represent. So either in this meeting or outside, it'd be nice to know if that's gone anywhere. It may well have not. May well have not done that. But I think as well. Where am I? Okay. I wanted to comment as well. I think there's reference in here somewhere to. Where am I? 154. I think it's on page 54. For a minute. I can do, but it's on the same topic, so you might want to take it at the same time. Okay. So this is page 154. You refer here to the financial impact at the bottom, paragraph 164. Based on 2019 underlying position, NUH's business as usual position is expected to be a recurrent deficit of 26 million by 2030-31. That does not reassure me that you can actually deliver that. It really doesn't. So I'd like to understand that a little bit better, please. So thank you.
Lucy?
I can have a go at the first, well, a bit of the questions. Phil might want to pick up the financial impact, if that's okay. So, health inequalities, you're absolutely right. It's a broad term, isn't it? And broadly speaking, our duty as commissioners is, as I said earlier, to plan services that reduce health inequalities and overall improve the health of the population according to a number of different measures. As an ICB, one of the things that we will be we go back to constantly is what's called our integrated impact assessment, because you're quite right, this is a huge reconfiguration project. It's got lots of different strands. It's got a small number of clinical priorities which we need to bring out when we talk to the public, but lots of different individual service changes to create what we hope is a configuration of services that's better for the public, for the next generation, and replace old estate, frankly, that's better quality. So from an ICB, and you can keep bringing us back to this when we come back to you, what's the overall integrated impact? And our integrated impact assessment looks at a different number of ranges. So equality, which is a massive, how does this differentially impact people with protected characteristics and other things that cause inequality? Quality, are we actually making the quality of services better? Well, in new estate, and we know new facilities give better quality services, less infection, unnecessary infection transmission. We look at things like travel. So, of course, when you reconfigure services, some people, we go right down to postcode level, may have to travel slightly further. Some people will have to travel less. This is the overall impact, looking at how we know people access services. Is that better for most people? And where it's worse for people, how can we compensate for that? And we look at things like environmental impact. We have to look at environmental impact, quite topical at the moment, isn't it? But are we overall improving the kind of environmental impact? So we will keep coming back to that. So it's not a simple answer, but we will have to say to ourselves, with the decision that we come to you in due course when we've been out to public consultation, and I'm in no doubt that we will get an overwhelming response to this at service level, and I'm in no doubt that the public views will be taken into account when we make our final decision. But the question you'll have to ask us is this going to improve the overall health of our population? And we have to say yes, because otherwise we couldn't recommend it to happen. So it's just multi-dimensional, Councillor Fold, but we recognise that is our principal duty. Secondly, new site option. I think it's fair to say there are no options for a new site. We will be redeveloping facilities on the existing sites. And I don't think it is blind faith actually around the continuity of the programme. We are fairly confident, but if the external environment changes, then we try and do it a different way. So but I keep saying this: there is no do nothing option. We have to, and this is the service model that we think will give the best care to our population. So we'll keep going and we'll keep coming back. In terms of the financial impact, clearly you build new buildings. Some aspects of them cost less to run. There are a whole range of issues we have to take into account. But overall, we have to demonstrate that the cost of these new facilities to deliver this new care model will be less than if we carried on and we did nothing. And that's a simple calculation, but it's a bit more complicated than that to work out.
Thank you, Lucy. Thank you, Councillor Paul. So the chart you referred to in there just demonstrates, as Lucy described, the impact of the preferred option which we want to put out to the public. So it's our duty to make sure that we are going to deliver the benefits which we set out, including the financial benefits as well as all the quality ones. So that's what it demonstrates. It's not a chart we should demonstrate that actually how does NUH as a whole organisation become sustainable financially over time. Clearly, we have a plan that we're working on at NUH to do that in the context of the system. The second element of that was your then confidence around delivery. Lucy talked a little bit about that. The only thing I would add is, as an organisation, if we are going to deliver the major transformation in our hospitals and reconfigure our services, we need a significant kind of resource behind it, and that's partly my job to manage an overall dedicated team to work on the development of these proposals over the coming years through to implementation. So it's a significant priority for us as an organisation as well as the system, which we'll need to resource appropriately over time with the right skills and experience to deliver it.
Okay, thank you for those comments, Mark and Lucy. And I think, like I say, we're very brave future government who withdraw that funding once it's been previously expected. I think we're very brave. I'm sure we'd all be united in oppose that, I'm sure, in the room. And just to really point about the finance as well, I mean, I noticed we'll go through the report, page 142, about the maintenance backlog you currently have. So my assumption would be, with the significant work going on, obviously not only that would be significantly gone, if not gone completely, that obviously would hopefully release more money to go towards said services rather than having to go on keep maintaining buildings which obviously are past their life, as we always said before, and I say paper over the cracks, for want of a better phrase. So I think, like I say, from what you've mentioned today, that funding coming, it's going to have a transformation effect not just on the buildings, but obviously future funding and care for the services. What I picked up, and I think as well before coming up to Carl, point I raised as well around the looking at the diagrams, the car park, everything's really important. No, it's not the sexy bit to talk about the car parking, but actually, in ongoing hospital, I think we always find that issue, especially with the City Council announced this morning they're looking at if they're going to keep funding Medilink and looking at potentially as well withdrawing the concession tram travel similar to proposal here. I think that shows that car parking may be more important than ever going forward. So with that going there, QMC could be really transformational for that. So, sorry, Councillor Clark, over to you.
Thank you very much. I thought, Mark, your phrase at the beginning was absolutely fantastic. I think you put into words what 500 pages actually say, so that was brilliant, and it gave me an overview now of what is planned, and it looks good. I have to say, we have to acknowledge that what we have at the moment, and you've actually acknowledged it in the report, you've put poor quality estate impacts on our ability to deliver high quality care and affects the experience of patients and staff. That's very true, and nobody is in any doubt that the staff that work there are fantastic, do their best, but what they're working in very often doesn't facilitate what they want to do. And I'll give you an example. I suffer from asthma and very, very often have to go for a chest x-ray. I used to go to have chest x-rays, so you walk in the main door, I used to turn right, go down a bit, and I used to go in the room there, which was lovely and nicely decorated, and have my chest x-ray. Last time I went, I was absolutely mortified that they'd moved it. And to get to it, I had to walk down a corridor of trolleys with people on them. Luckily, I had a mask to put on. Nobody asked me to put on a mask because all these vulnerable people were in there. That's where I had to go for my chest x-ray, and that's how bad the situation is with regards to space for urgent care. And so it's absolutely desperate that we need this. Again, just to echo what Councillor Fold said, and you gave a good question, but to put it into perspective, in 2030 I'll be 68, in 24 I'll be 78, and I consider myself quite young, really, to be honest with you, but there you go. Yeah, a couple of things. I'm a bit concerned about what was said about the medical school, because the medical school is one of the best in the country, and I would hate to be in a position where we lost that. That would be a huge loss for Nottingham. And also, with a shout out to health inequalities, and I don't expect you to answer this, but one of the biggest health inequalities is the fact that 1 in 8 men will develop prostate cancer at some time in their life, but there is no screening. Very often there are no early signs that you've got it, and that is a health inequality amongst many others. But I'll shout that out because it's not very often it's said. Thank you.
No, thank you, Councillor Carr. Anyone to come back to this point?
I'll just clarify one thing on the medical school. I think that's quite important. The university is still thinking this through, but they have indicated their intentions. But again, phrase the day, no decision has been made. But I think what they have been really clear on, and this is kind of stated publicly, is that whilst the intention is to vacate that building that's on the QMC, it would be in order to build a much more modern and larger facility at the north end of the Jubilee campus, so not that far away. And I think it would be fair to say, if folks have visited some of the buildings on the Jubilee campus, in terms of how they look and how they feel and how modern that is, that would probably be a more attractive proposition than the kind of 60s, 70s builds that's currently there. So I wouldn't want anyone here or listening to this to think that there might not be a medical school or anything like that. That's certainly no one's intention. In fact, it's a move that's, I think, been broadly really positively received, because it'll mean attracting more and being more attractive to people who want to take up a medical career.
I think that's a really important point to make on there. It's a good point to raise, Councillor Clark, because people will be asking me to put down there where, we want to make sure we attract the best people to Nottingham who want to study, because hopefully they'll stay here and maybe look after us in our dotage, don't we? Absolutely, or when we need care. So thank you very much for that. Was there any other member wish to raise an item that's speaking? No. Okay. Well, I mean, obviously, again, with the report, thank you again for coming to present an update. And I think from what I picked on the committee, all in agreement that we're going for the recommendation moment. We should be proceeding to your consultation when you decide if that's something that you want to do. But I think the points already raised by members from Councillor Walsh is the communication parts. Again, just make sure we get that right, because we do not want any negative connotations to come on the back of this report. I'm sure you don't, and we definitely don't either. So if that can be, I'm sure we'll be taken on board and make sure we get that. Just make sure we're absolutely united on that front to go in there. That'll be absolutely fantastic. And obviously, if we get an update in the future, we can bring that back to committee just to let you know we're getting that progress. So we cover the recommendations at the start, and in true fashion, the laptop's timed out because we're talking that much. So let's come in to recap with everyone. I should refer to the 500 page in front of me, but there you go. Let's see, get onto that one. That's fine. So the recommendation once again was to note the content of the pre-consultation business case, consultation document and consultation plan, which we have done in detail. Note the responses to the recommendations previously made by members regarding engagement with the public. And again, I know that was brought up by Alex on a specific slide in the report in detail, so thank you for that. And to confirm that there's no objections to the ICB proceeding to public consultation should the board agree to do so in its January 2024 meeting. So just to raise hands, all those in favour of those recommendations? Any against? Any abstentions? Thank you very much. So that's the vote carried. So thank you very much, and thank you, colleagues, for attending today your time. So, home stretch, work programme. So,
I forgot to mention that Councillor Wilmot had to leave to attend an urgent.
Yeah, he did see me in the so we've recorded that down to Councillor Carver. Thank you for raising that again. We've got that in the minutes, so thank you. Yeah, so just give one moment for the colleagues to leave. No rush, don't worry. Don't anyone else fall over, bless you, so take your time.
I'm not ignoring everybody, but I've got another meeting at 1:30. I'm just cancelling it. If you wonder why I'm on my phone.
Well, we'll be hopefully not too much longer on the report. So we can kick off anyway before Noel comes in, because the first item I'm going to hand over to. So we've got the work programme in front of you there. Just before we get to the main work programme, just want to give everyone an update on was for a task and finish group on school readiness that Councillor Eddie will be chairing. So hand over to Councillor Eddie just to give us a quick update.
So the update that I've got so far is that the invite's been sent out to all the groups. I think we're just waiting on a couple more people to sign up for it, and then we're looking at probably having the first meeting the second week in January, so January the 9th, if that works for people. But we'll send out an invite and hopefully get that started as soon as possible. But I think it waits for one person from the independent group to join us, if that's possible.
Yeah, Noel has sent it out to the invite to your. So I think I was into Samantha as business manager, but if you have a look, and obviously, if not, the committee can join. Obviously, in terms of rules, it can be an only member of the council if they need to join. If they can't be, but yeah, that's fine. If you come back and let us know that one, Councillor Paul. Yeah. Yeah, absolutely. Yeah. Yeah. Sorry.
Yeah, the whole point of it is just for us to look at it as a whole. So the more the merrier when it comes to it. So if you can't make it, I'm very happy for people to sub. Yes. Yes, definitely.
Okay, so we'll go into the substantive work programme itself. So obviously we had a couple of bit potential change today. Obviously what was mentioned by colleagues from Newark Hostel, they might have an update for January. So obviously, as a minute, we need to make sure that update, well, one, would have the papers in place and we'll be able to actually present a substantial item to the committee. So what I hope if you can, with your indulgence, is to make sure that we can obviously have this conversation with our colleagues to make sure that those reports can be in place before we fully commit to it on the work programme, and we can obviously give an update to all the members just before, obviously make sure the specifics in which you have something meaningful, substantial to present to the committee on that date. You've got enough time to look at the papers and take consideration of them. So there'll be a bit of flexibility with the work programme in that sense. So if we can get onto the work programme in January, we'll obviously look at potentially moving one of the January items back. I'll be conscious there'll be three substantial items on the agenda, and we may be here a long time on that one. So if this lovely time sensitive, I'll hand over to Noel on the technicalities of that.
Yes, I was just going to say, I think I'll have to have some conversations with the external organisations we've already lined up for January, because if we are going to take the Newark UTC in January, we'll look to move one of those back. But with as the chairman says, with your indulgence, we just need to do a bit of boxing and coxing in the background and get things lined up for the January, February, March period. Thank you.
So that's okay. That once we have that update, I'll then circle notes out to all members. Then if there's any issues or discussion about that, feel free to come back to myself or Noel, and we'll agree that. Would that be okay with your indulgence on that? Yeah.
Councillor Pringle may, if he can, might want to.
Yeah, absolutely. Yeah, I mean,
I thought about that when Councillor.
Yeah, no, absolutely. Yeah, of course we can update, and I'll make sure that's clear out to members. No problem at all. So
we've asked him. We've had a conversation about him, but I think to be here is a bit different.
Yeah, of course, absolutely. So look at the rest of the work programme. So the February item down there for mental health services and support in school. So I've had a conversation with a couple of stakeholders already about mental health, and to me there is a wider piece of work around mental health provision in terms of the bed provision we have, in terms of for Nottinghamshire and the care we give to our people, both young people and ones who obviously don't qualify young people, because obviously as a council, not only are we supporting people potentially in combinations with children's homes who perhaps potentially should be in proper mental health provision. I think there's a wider piece of work about what mental health work is being done across the county. So my proposal would be that February item we look to expand in a bit more detail to look at the mental health provision that currently plays across Nottinghamshire and to scrutinise that as a group and any recommendations to go forward. Would there be any objection to that? Councillor Walsh?
It's not necessarily an objection.
Yeah.
It's myself that put this forward because it's been raised as a shadow position.
Mm-hmm.
There is a situation where there should be mental health support in school where that is not happening.
Okay.
And so what is critical and what we need to get really, really moving on fast with regards to this is where does that mental health support exist at the moment and where doesn't it exist, and how we plug in that gap. The waiting times for CAMS are 18 months for self-harming at the moment. So I totally understand what you're saying. In fact, there is a bigger picture.
Mm-hmm.
There is a level of urgency, I think, in relation to schools. And my worry is if we go towards the bigger picture, that becomes a massive meeting and a massive issue. I think, if anything, with mental health services, we need to start breaking it down in how we deal with it. And there is a specific issue and need with regards to mental health of children and young people in Nottinghamshire, particularly post-pandemic. When you go into any school and speak to any head teacher or any Senko, they all tell it. Every school that I've been in have said that to me as one of the key things. It is critical that we have that discussion and scrutiny as quickly as possible.
No,
So obviously it's up to you.
No.
I don't want to cloud what I raised in the first place. That's my own.
No, I completely agree on that, Councillor Walsh. So my proposal then be in line with that was to be that we have an item on mental health services for children and young people. So it's at the school there, and also because obviously that is connected, not just, I'm sure you're aware, not just for in schools, but the support they're getting outside and around schools to complement that. And then we perhaps look at a future item for mental health provision for adults, and in a separate item just based on the item. Would you be happy with that? Everyone else okay with that as a committee? Then look, we've got the other dates in the item there. I know there's a number of items that are to be programmed. There's a couple of items there, for example, if I pick an example, the first one there, the provision help Newark Cavill Centre, where want to look away, would it be worth a brief note for members first of all to look at where our competition is and see if we still think it's worth scrutinising, not worth, if we still need to scrutinise, ask those questions, because obviously I'm just conscious that we just need to make sure with some of these items that we first of all know exactly what the background is and if we want to bring them forward, because there's a number of items on there which are very important. We want to get programmed as soon as possible, and I hope you accept. I've been in a few days, so I just need to have that chat with officers just to make sure how we can get these items on the work programme that can be not only delivered by ourselves, but our external partners can obviously make sure they can get the information and come to present to us in the right way so we can scrutinise. Sorry, Councillor Martin.
Yeah, a couple of things.
Yeah.
One is on your previous item, mental health services. I think it's because there was a change in provision at Bassett Law to do with the new hospital they set up at Mansfield, so that's why you'd be following up to see how that's panned out.
Okay.
Right, because they're putting a new A&E in at Bassett Law, aren't they, which is a village, basically, and within that village is contained child mental health provision, short term, but they changed the adult service provision to the new hospital at Mansfield, so that's why it's on the work programme to follow. Well, it should have been on the work programme to follow that up to see how it's worked out. And as regards the Cavell Centre, we've just heard of the delay in the work at NUH because of RAC, so pushing that back to beyond 2030, which is 6 years ago. Implementation supported locally by Ashfield District Council of the Cavell Centre at Hucknall would greatly assist health and well-being in that area and probably take some of the pressures off, and it would be a much quicker achievable goal than what they're doing at NUH.
Okay, well, so if we look at a bit more to see how that would fit in, just want to be clear on the scope of the scrutiny to make sure what we can actually as a committee scrutinise, because I know there's some behind the scenes in terms of the funding, etc.
Scrutinise the provision.
Yeah, absolutely. So, Councillor Carr.
Absolutely, Councillor, we can have a look at, as well as to what our role is as a health scrutiny, is another health inequality, which is the difference in numbers between men and women who commit suicide. It's huge, absolutely huge in men, and it'd be interesting to know what the health service and other authorities are doing to actually try and redress that, particularly young men, which is a tragedy.
Absolutely, we can absolutely put on work plans to look at how we can put that in. So, if I was happy at the moment in terms of what's on there, just to quickly talk about the visit to Bassett Hospital, obviously that is absolutely on the agenda to do. Obviously, as has been alluded to, there's currently some construction work going on there. So, to me, it makes sense we wait for that construction to finish so we can actually see if that's delivered to what we expect it to be in the original term and see how that's impacted there. So, if everyone's okay with that, that would be my recommendation at the moment. So, I think it's due in the summer. Look at Bassett colleagues at summer, so it's around late summer. So, let's see if we can. Potentially, if that's on course to be done, then we can arrange a visit towards the later part of next year if that works, if that's okay with everyone. Councillor Welsh?
Yeah, it's a request really. I know we've got a really healthy work programme already, but it's a request with regards to lung disease and pathways with regards to lung disease. There's been a huge increase across the country, and from what I can gather in Nottinghamshire there has been, and there isn't always the capacity to deal with them effectively, and actually from other than lung cancer, other diseases aren't necessarily dealt with in a timely manner, and it affects some areas of Nottinghamshire more than others. So I was wondering whether you would possibly consider putting lung disease and the pathways in which people get treatment for it on the work programme going forward. As I said, there is a distinct increase post-COVID of people that have got fibrosis on their lungs, and it would be fitting, I think, at this stage for us to scrutinise what is happening and what those pathways are at the moment.
Okay, well, I'm prepared to admit it. Would everyone be like to see that on the work programme to go forward? An item on that. So if we go in, look at that, just make sure to get the technicalities, and then maybe speak to you, just get some more information on there. As alluded to, we do have an extensive, I say, waiting list is for want of a better phrase with the setting we're in, but to get onto the work programme. So we'll look at the items to make sure what's obviously more time sensitive, and so we can work out to get them in. Yep. Okay. Yeah. Go on then. Yeah.
Just because one of the ones that we keep raising regularly is the issue around health inequalities, and I know it's huge, and you probably need to find a way of framing it better than just health inequalities. But I'm very conscious that when we asked that this morning, and it's happened before, the response is actually down to how people access healthcare, and that's not the whole extent, is it, of health inequality. It's actually because there's a lot of talk about early intervention and preventative kind of type work, and a lot of that is actually commissioned by the ICB, isn't it, by kind of the ICS and by us in terms of public health. So I think it would be really good to actually look at health inequalities and what we're doing to tackle the inequalities, rather than just making sure they can get to an A&E in half an hour. Do you know what I mean? It's that kind of difference in terms of approach. Again, it's going to need a bit of thought, that one, so I don't expect it to be on next time, but I think it's something that we're all concerned about. They say they're concerned about, but I'd like to know what we're doing that's impactful.
If the committees have to look at that, we'll take that away and see how we could work that into an item that we could scrutinise when we fit in the work programmes. Okay, so anything else you want to know before telling us that?
No, that's very useful. And to be honest, there's quite a lot of sort of historic things on there that possibly have rolled over from 22-23. And I think if we look to front load perhaps some of the more recent things that you've raised, and we conduct some sort of back of office appraisal of things that maybe have been on here for a long time, either see whether they can be done somewhere else or perhaps removed with justification, and bring that to a future meeting, just so that we have a more contemporaneous work programme.
My final observation was, for the January meeting, would there be an objection to bringing forward the meeting to 10 a.m. rather than 10:30? The reason is a meeting clash afterwards, and just again with the potential items on there, would everyone? And then we'll also review if going forward a 10:30 start works better for members. I know some people have a longer journey than I do, so I want to be conscious of that, but also conscious when we start to kick over lunchtime elsewhere, it might be better just to align that. So if we say we start that next time and then see how that's gone for people with journey time getting here and review that, will that be okay? Okay, we'll look at that. Absolutely. I'll make sure I set the right dive on that one, no problem. So thank you much, everyone, then, if we're okay, the work programme there, and thank you much for your attendance today, and see you before, wish you Merry Christmas and Happy New Year. Thank you.
Yes, if you stop the recording, thank you.